Okay, yes, we're ready to start.
Wonderful. So I want to welcome everyone once again to another meeting of the Community Vaccine Advisory Committee. I'm Dr. Nadine Burke-Harris, California Surgeon General and co-chair of the CVAC, as you know, along with Dr. Erica Pan, our state epidemiologist. And to start off this meeting, we will start with with an update of our meeting process as we move into now meeting 9 of this process. And I really want to start by thanking all of you for being here. You all have put a lot of time and commitment into this process, and we're really grateful for you to be here. We've got lots to cover today, so we'll move right into our meeting process. So Bobby, do you want to take that away?
Yes, I will. Thank you. I do need to make an announcement to the telephone operator. If you could put our line back in the communications room so we don't hear double, I'd appreciate it. And welcome again, everyone. Just to review the meeting process for everyone, as everyone knows, we appreciate that the members of the Community Vaccine Advisory Committee will keep their cameras on so we can look at each other and, as I like to say, pretend we're in a room all together somewhere in Sacramento. I think everyone by now knows how to use the hand raise icon in the participant section. And when you're ready to make comments or ask questions, please do use that. We have our 2 ASL interpreters with us again today, Katie Sales and Vicki Kennedy. And we also have closed captioning for our members and members of the public. Members of the public are listening on a telephone listen only line, both in English and in Spanish, and also through our live streamed YouTube channel. Public comments are always welcome at the COVID-19 vaccine outreach at cdph.ca.gov email address. And as always, if any members have technical difficulties with the Zoom, if you can put that into the chat, we'll see if we can help you resolve those. Thank you, Dr. Burke-Harris.
Thank you, Bobby.
Would you like me to go on to the summary of the public comment?
Yes, that would be wonderful.
Great. So I just wanted to take a few minutes to summarize the public comment that we've received since January 19th, just as a reminder to the Community Advisory Committee members and the public. We cut off our public comment 2 nights before the meeting, so for a Wednesday meeting at 5 o'clock on Monday, so that we can assemble the public comment and send it out early Tuesday morning to members of the Community Advisory Committee so they can review the public comment in detail. We received 269 individual or organizational submissions of public comment during the period from January 19th to February 1st. I will summarize the highlights of those comments quickly. The UC Berkeley School of Public Health offered a comment that we should use an anti-racist approach to vaccination distribution. We had 11 individuals comment that the process of getting a vaccine needs to be simplified. They can't figure out how to get a vaccine. There's no public announcements of where to go to get vaccines. We had 2 individuals comment that the accessibility of vaccine facilities needs to be improved. There needs to be parking and vaccine locations need to be well signaged and posted. We had a number of comments about vaccinations for healthcare workers. One asking optometrists to be vaccinators, another asking veterinarians to be vaccinators, and another from the California Behavioral Health Directors Association asking that it clearly be identified that behavioral health workers are part of the healthcare workforce in phase 1A. We had many, many comments from people who wanted to be prioritized higher to get their vaccine sooner, including people who are homeless and working with the homeless. 3 comments from farm worker organizations, including the Santa Cruz County Board of Supervisors who wanted farm workers to be prioritized. 6 comments about school teachers, school staff, additional comments about childcare workers and Head Start, comments that people over 65 should continue to be prioritized, people who wanted individuals over 60 prioritized higher, and people who wanted individuals 50 to 64 prioritized higher. We had 4 comments from IHSS workers or IHSS participants wanting to be prioritized higher. We had many comments from people with disabilities who are under 65 wanting to be prioritized higher, 32 comments, 54 comments from people with underlying medical conditions who are under the age of 65, who believe their conditions, such as diabetes, cancer, HIV and AIDS, hepatitis, autoimmune conditions, lung disease, chronic kidney disease, and blood diseases, should be prioritized higher. We had 24 individuals asking that adults with intellectual and developmental disabilities be prioritized higher. We also heard from the judge in a superior court, a presiding judge, the Alameda County Bar Association, and the Association of Public Defenders that all court-related employees should be prioritized higher. We also heard from the cannabis industry, the utility and energy workers, dock workers, the airline industry, the food industry, and the USDA inspectors, from bedridden and homebound elders, from people in waiver programs, the biotech industry, family caregivers, retirement facilities and independent living facilities for seniors, contractors and construction workers, the semiconductor industry, the port authorities, laundromat workers, the communications infrastructure contractors, code enforcement officers, research and testing labs, global communications, immigrants in detention facilities, residential camps for children and youth, and dock workers, that they all be prioritized sooner. We also had 4 individuals who offered their assistance in giving vaccines and making their facilities available as places to give vaccines. We had 1 individual ask that age be used as an equity factor. 2 individuals who urged us to keep the age-based approach. 1 individual who wrote suggesting that we not give vaccines to prisoners or teachers who are working at home. UCLA's CHIS program provided detailed data on Native Hawaiians and Asian Pacific Islanders concerned that the Healthy Places Index misses the impact of COVID-19 on these communities. We had 1 individual who wanted the data on why the Moderna vaccine adverse events caused a pause in the Moderna vaccine in San Diego County. And we had 1 individual ask that the cancer community be a member of the Community Vaccine Advisory Committee. Thank you, Dr. Burke-Harris. That's the summary of the public comment that was received before this meeting.
Thank you very much, Bobby. And, you know, we're very, very grateful to the members of this committee and also the members of the public for sharing all of your comments, concerns, your advice, for the data that you share. As you heard from Bobby, this is reviewed and we work very hard to incorporate as many as possible of the concerns and the issues that are raised into our work processes and into what we take forward. I wanted to start this meeting by anchoring again, as I try to open every meeting, in the values and the foundations with which we approach this work, which are the foundations of safety, equity, and transparency. And I want to kind of remind all of us about how we go about ensuring those pieces, and really thinking about the the in the face of a limited vaccine supply, right? We recognize that the process of determining how vaccine allocation is prioritized is done first by ensuring safety through our Western States Safety Review Committee, right? That looks at the data and determines the safety of the vaccines. And then through this body, right, as an advisory body, to receive public comments and to hear all of these questions and concerns. And then we take your comments, concerns, and recommendations and share them with the drafting guidelines work group. And the drafting guidelines work group are charged with the difficult responsibility of making these recommendations to the administration. And we're doing this in, we've structured this framework of this three-part groups after the recommendations of the National Academies of Sciences, Engineering, and Medicine, who in their wisdom recognized that there would be intense advocacy for prioritization of vaccines, and really sought to create a framework in which public and community voice could be heard and incorporated in the process, while at the same time charging the responsibility for making these difficult recommendations in the hands of medical and public health experts after they have done an in-depth review of the data. And so as we move into this process, I want to share with you our collective gratitude for the robustness of the recommendations that have been shared, the highlighting of the concerns, and really the way in which this group has helped us maintain equity at the center of the work that we do. And I want to state something explicitly. I believe that it's been stated before, but it's very important for me to restate that when we're talking about equity, that includes equity in terms of providing service and accessibility for individuals with disabilities, right? And so I want to make sure that when we think about equity, we absolutely think about racial and ethnic and socioeconomic equity, but we also want to think about equity in terms of ability. And I want to make sure that that is stated explicitly at the beginning of this meeting. So today, as part of this meeting, the other thing that I want to do is you all have shared many, many questions in the chat, in our conversations, and I want you to know that we are working very hard in between meetings to try and get as many answers as possible to the many questions that you guys ask. So for today's meeting, over the course of the presentations and conversations you're going to hear, we're going to touch on, we've heard many questions about what is the status of the federal long-term care partnership, right? The partnership with the pharmacies. And so we will speak to that question. We hope to bring you answers to that. You all asked us the question about, as we transition to an age-based system from our blended age and sector-based system, where do inmates in correctional facilities, homeless shelters, and other programs, as well as residents of detention facilities, both public and private, where do they fit in this new approach? And we will hope to bring you as much information as we can about that. You asked a question about how will vaccine hesitancy among healthcare workers and other Californians be addressed by the state? And when we talk about engagement, we're going to share some information about data on healthcare workers and addressing barriers for healthcare workers as we talk about the overall research that we have that is informing our engagement and communication strategies. You all at the last meeting asked, how will employers participate in vaccine distribution in an age-based approach? And in a section of this meeting, we will hear from uh, GovOps, our State of California government operations, about how we're operationalizing our vaccine distribution strategy. And in that, we have asked them to speak to this question about how employers will participate in vaccine distribution in this age-based approach. And the other question that we've been working hard to make sure that we have answers to respond to is, folks ask the question, how will notification of individuals about vaccinations work? And we can share, we'll share a little bit about that. We actually will have more for you about that in the next meeting. But as we move into this, what I want to say is that your questions, your comments, your concerns are heard. We're working very hard to bring this information back to you. At the end of this meeting, we're going to end the meeting by again soliciting your questions and concerns. We try to pull as much out of the chat as possible and be able to respond to it. But again, we've created a space for that. And so with that, I want to start off the meeting with any welcoming comments from my co-chair, Dr. Pan, and then Dr. Pan will start with an update on vaccine supply.
Great. Good afternoon, everyone. Thank you so much, Nadine. Yeah, I wanted to start, as I often do, with just both sort of where we are as a state. And I think for me, it's also just been a little bit of a moment of reflection. We have just hit a little bit over a year. There's been a few anniversaries recently. The first, cases in the United States. I remember very vividly first activating when I was at the local public health level, our emergency response for public health, and just sort of starting to see that this was evolving into a potential emergency. And of course, in that moment, a year ago, I had no idea we would be where we are now. I think, we have gone through a really huge, difficult surge this winter, much more above and beyond, I think, what many of us would have imagined. But we've gotten through that. And I am very happy to share that we're very encouraging trends right now. Our cases are decreasing. They're actually decreasing quite rapidly. There's been some decreases in testing, which made us concerned that maybe it's just that we're not testing as much, but we're also looking at something called test positivity that's also improving. And really importantly, hospitalizations and intensive care unit admissions have all been decreasing. So those are great signs. I do also at the same time want to remind people that we are still at levels that are around what our peak was last July. So we are still not out of the woods yet. We are absolutely thankfully on the other side of this surge, and things are definitely getting better. But as we lifted that regional stay-at-home, I think we still have a lot of tight restrictions, but thankfully a lot of us can do a lot more things. But we cannot let our guard down. We still need to be doing all the basic things we keep reiterating, but wearing a mask, having it be well-fitting over your nose and mouth, keeping your distance, staying home as much as possible, and really minimizing gathering. And we are here today, and as always with this group, with this very exciting, light at the end of our tunnel with vaccines. That being said, I think the other things that have happened, we've all endured a lot over the last year. I think everyone has made sacrifices over this year during this pandemic, and certainly some more than others, and some have really, again, been disproportionately impacted. But we've gotten through this part together, 40 million strong. And there were times during that surge, especially in certain parts of our state, where, healthcare was really stretched to contingent levels of care. Thankfully, I think we did, again, collectively as a state and a healthcare and a general community, we were able to get through that with some contingent levels of care, but we really did avoid crisis levels of care. And I'm really proud of our state for doing that. We managed to level load the resources, make sure that resources were where they needed to be so that we didn't have to get to that. And now, I want to just call out all the healthcare heroes that really endured all of that. And now we're here again with the light at the end of the tunnel, but it's in very small amounts. So we're all collectively allocating scarce resources. And this is just particularly difficult at all different levels. So I just want to also thank all of you and your partnership in the community and Californians. This committee's input is extremely valuable to us and to all Californians. And we continue to learn and grow from our experience in this pandemic. I've learned so much over the last year. And, you know, we are just evolving and learning, and we also really learn from feedback and input. So want to thank all of you. You continue to make us better. We will continue to get better. And, you know, again, some of this is having to learn as we go, and some unanticipated challenges continue all the way. But I think all together, again, 40 million strong, we get through this together, and we're in our home stretch. So really excited for that. So with that, I think we can shift to the next slide, and I can talk a little bit more about, let's see, some of our numbers and things like that. Let's see. And actually, we can stay on this for a moment. So I wanted to just highlight, I know people have a lot of questions about supply, how many people we vaccinated, how much are we getting? So our sort of numbers about how many have been delivered to California, 6.3 million doses have been delivered to California, and we have vaccinated almost 3.8 million doses to date. And among those, over 600,000 people have gotten 2 doses. That means over 500,000 or over 600,000 people are fully vaccinated in California. And by our estimates, and we've done a lot of work over the last several weeks to really improve the data that we can collect on doses administered, about 2/3 of our supply has been administered. So that is, and a lot, again, people have been working, you know, many people have been holding on to second doses with the inability to know exactly how many doses are coming in the next week. We do continue to hope that will stabilize over time. We've moved actually as a state from, you know, we were, as many of you heard, among the lowest on the Bloomberg rating. We are at 29th now amongst all the states. And among the large states, we're doing quite well as far as getting our vaccine out. So again, I think we had, you know, the rollout was difficult in the middle of a surge. And took us a little bit of time to be getting up to speed. And we know there's a lot more capacity as we talk to people on the ground. And as we set up, you know, all these various mass sites, I think really our limiting factor is vaccine, but a lot more capacity has been increased. And you'll hear more, you know, throughout this meeting about all the other things we're doing to improve our efficiency and our capacity as a state. As far as projections, I think, again, we're still hoping that there will be more clear projections. The last we've heard from the federal government is we'll be able to get sort of 3-week out projections, which is a little bit better than the 1-week projections, but we're still not getting a lot of definitive numbers. And of course, some of it will be based on when new vaccines are approved and then how much those manufacturers can supply. So we will continue to keep you all and the public up to date as much as we can on, you know, as we know, ongoing projections. But right now we're still in a very much a week-to-week basis. So with that, I'll move on to talk about the long-term care partnership. You can go to the next slide. So as many of you know, we have a CDC pharmacy partnership for long-term care facilities and skilled nursing facility programs. Go on to the next slide, please. And so CVS and Walgreens have partnered nationally with CDC, and here's our data in California. So they have conducted, their plan is to schedule and conduct 3 vaccine clinics at all of these facilities on site. So they first started the program for the skilled nursing facilities, that was part A, on December 28th, 2020. And then the assisted living facilities and other facilities started on January 11th. Over 16,000 long-term care facilities, so 98% of the total signed up have clinic schedules. And you can see this nice graph of kind of the waves that have gone here. So these different colors, the blue is the first clinic scheduled, and then the second and the third. So they try to go to that third time in case someone missed, you know, the first or the second to get those vaccinations in. Next slide. And then this is actually a cumulative picture to look at, sort of starting again at the end of December, moving now to the beginning of February where we are. So as of February 2nd, almost 350,000 doses have been administered in these facilities. Almost 300,000 have been first doses, and a little over 50,000 are second doses. And then you can see the breakdown here of 188,000 resident doses versus 159,000 staff doses. So I think we all know, and there have been a lot of questions from this group as well, that, you know, like the overall vaccine rollout, I think it was a little bit of a bumpy start. Some of the challenges that we've been hearing, both from people on the ground and the pharmacy leaders as well, is that the logistics have been huge. We have 17,000 facilities in California. Once again, just like all of our vaccine coming out, we were in the middle of our worst surge ever. A lot of the rest of the country had, been through most of their surge, and it kind of moved its way west. And so we were one of the last, I think, to get a huge peak, and it was right in the middle of when we were getting vaccines. So, there are recommendations by the CDC that people with acute infection should defer vaccination until recovered and have complete isolation. And there's also considerations in the middle of an outbreak on when and where to vaccinate. So our healthcare associated infection team actually developed what we call yellow zone infection control zones, so that to be taken into consideration when the pharmacy vaccinators would come into these sites, and how they could safely and effectively vaccinate during these outbreaks. But that led to some other logistical challenges about who could be vaccinated, which areas of the facilities they could be in. Data reporting, amongst other providers, has involved many systems, both new systems by the federal government, the state government for us, and CVS and Walgreens. So there's been ongoing work to improve the data flow, again, from these doses administered and getting that to us so we can report back to ourselves and to you and see how it's going. So that's an ongoing work as well. There were definitely communication issues early on, not hearing from the pharmacy partners themselves and into sort of the state and public health on where they were, and then us needing to communicate that to local health. But that's really improved over time as well. There were a lot of challenges with pharmacies being able to reach some of the facilities. We heard that they were calling over and over again. It would take sometimes, several times to actually reach someone to schedule the clinic times. And then emails also, were sometimes ignored, and some thought it was sort of a spam or junk mail. But again, we've had very high level conversations. I know representatives from our governor's office have met with, the CEOs of these organizations and really made sure that things are improving as we move forward. And we're very encouraged by all the progress that's been made. And as you saw from the prior slide, all of the facilities should be completed by mid-March. Let's see if there's any other key things I wanted to share with all of you. So all of the skilled nursing facilities should be done by the end of February, and all the other ones by the end of March. And I think, interestingly enough, you see these absolute numbers here. I think just to also, I know a lot of people have had questions about this. As far as uptake, we've had really good uptake among residents, which is 78% among residents in these facilities, but unfortunately only less than 40% of staff, around 37% of staff, have received more than one dose through this program. So we really want to continue to work with, which was another question and theme moving forward, about how we work on vaccine hesitancy amongst healthcare workers and others. So we'll be continuing to work on outreach in that setting as well. And we'll continue to keep you and others up to date on what's going on with this program. Let's see, next slide. I think it might be, yeah. So with that, I will turn it over to my colleague. I think Marta Green might be next, or Paul Markovich.
Dr. Pond, before we jump in with Marta, there are two questions that I see in the chat. I don't know if you have this information at your fingertips, so we may have to come back. But do you know how much supply we anticipate for next week?
Next week, I don't have it at my fingertips, so we will get that to people though.
Thank you.
I will say previously, like, first doses have been in the 500 to 600,000 range, and then continuing to get second doses to make up for those initial ones.
Thank you. And then there was a question: total number of long-term care staff and residents. I think we'll have to get back to you on that, because I don't think we have that number at our fingertips. I do see that Lisa Coleman put some figures in the chat, but I don't. I think we would have to confirm as to the numbers that we are working with. And there's a question from Mike Dark about why is there still no state dashboard? Interestingly, there is a state dashboard. We did not have time in the agenda to present it today, but if you'd like a presentation on the state dashboard, we can do that at the next meeting. There was another question: are the 78% and 40% Dr. Pond cited national or state figures? Those are state figures for the state of California.
Yeah, and the dashboard will be continuing to sort of update and improve as well. So it's an increasing, but it's on the COVID-19 website when you go to the vaccines page.
Thank you so much. So thank you for those questions. And now we'll turn it over to Marta Green and Paul Markovich to share more about accelerating vaccine distribution and administration.
Thank you, Dr. Burke-Harris. I really appreciate the opportunity to be here with you, all of you today, and meeting some of you for the first time, but many of you I've had the pleasure of meeting with previously. Just by way of background, as Dr. Burke-Harris said, my name is Marta Green. My day job is actually I administer the health plan program for the California Public Employees Retirement System, but I was asked to come over to help stand up our new third-party administrator program that we will be using to administer vaccines statewide. And it's because of my experience doing that for the California Public Employees Retirement System that I was asked to come and do this. So I'm going to give a brief overview of what this program is going to look like. And then I'm going to turn it over to Paul Markovich, the CEO of Blue Shield of California, to talk about his commitment to equity and this project broadly. So next slide, please. So first, I kind of just want to talk about what we're doing here. Like, why are we doing this? What does this mean? What's the context in which we're working? So we are working to build a statewide vaccine network to ensure equitable delivery of the current and future supply of vaccines. The state, what's going to be different about this is the state will allocate vaccines directly to providers to maximize efficiency and also have real-time transparency into where vaccines are at all times. These vaccines are truly the most important and precious resource that we have in California, and we need to know where they are and how quickly they're getting into our communities, and most importantly, our communities of color. We are going to enter into a cost basis contract. So what a cost basis contract means is that Blue Shield will pass its actual costs for administering the third-party agreement arrangement to us, but will not be able to profit in any way off of this arrangement. The network for the statewide vaccine network will include providers who meet various program requirements, such as the ability to give us statewide real-time data, meet our equity goals and metrics, have certain volume capacity targets. We're going to have a wide variety of providers in the system. It's going to include existing health systems, hospitals, clinics, pharmacies, mobile sites, mass vaccination sites, and will also include home-based vaccination. Next slide, please. So what is a third-party administrator? It's kind of an archaic term. So what it is it's an entity that selects and manages a network that is responsible for the delivery of healthcare or other services for a group of people. I administer a third-party administrator contract over at CalPERS for our self-funded health program. They're very common. Blue Shield of California was selected to be the TPA for the state and is tasked with creating that network. A little bit about Blue Shield, you probably all know them, but it's a California-based nonprofit. It has a network that covers all 58 counties, and it has experience as a third-party administrator. And as I said, it's a cost basis contract. Next slide, please. So let's talk a little bit more about the key functions. So what does this mean? So they will develop and manage the state vaccine network contracts. So that's the contracts with the providers. Those contracts will include the ability for the providers to receive startup costs to do mobile clinics, startup costs to get on the network, startup costs for mass vaccination sites, and will also include incentive payments for meeting various metrics that we set out. And those incentive payments I'll get into more later, but they'll include things like real-time data entry, meeting the populations we are trying to serve, administering vaccines in the lowest healthy places index quartile, and other various metrics. They will also have a communications plan component with the providers to help give them real-time information about state expectations regarding tiering, regarding policies and procedures as established by our colleagues at the Department of Public Health. They will oversee the network and make sure that the network is performing to state expectation. They will implement the vaccine distribution that is set by the state of California, and including consideration for hotspots and all of the equity measures that we'll get into later. And then they will feed provider data as required to myturn.ca.gov and statewide dashboards. So there's real-time transparency regarding the performance of the network and the penetration of vaccines in California. Next slide, please. So why are we doing this? Like what are some of the challenges we're trying to fix? Right now, we have vaccine administration recorded on multiple systems, including paper-based systems at some sites. There are lags in data reporting. There are gaps in the data that's reported, and it makes it very difficult for the state to support real-time decision-making in where vaccines are deployed. So in the future state, we want to see major consolidation of the systems, real-time availability of data for monitoring of where vaccines are, as well as reporting, a user-friendly tool for the public to register. We've all heard the stories. We heard it in public comment that Bobby talked about this morning. People don't know where to go to sign up to get a vaccine. And we want consistent tracking of follow-up doses so we ensure that all individuals get the second dose and achieve that, that safety. Next slide, please. So how are we going to ensure transparency? So we are going to determine and approve all of the vaccine distribution criteria. We will provide these criteria to our third-party administrator partner to achieve equitable vaccine allocation based on population needs and COVID-19 burden. We are going to report administration statistics, including all of those key metrics I talked about, such as volume, geographic distribution, and equity metrics through a public online dashboard. Next slide, please. So what are our guiding principles? Well, first and foremost, as I said to everybody that I've talked to, we're here to save lives. So that's what we're here to do today. We're here to save lives. And how are we going to do that? We're going to do it through equitable distribution of vaccines. That means targeting vaccines that have been disproportionately impacted by COVID-19. We want to ensure that the vaccines are distributed efficiently and with minimal waste. So we don't want to have any wasted vaccine or vaccine sitting in freezers or not allocated appropriately. We want our approach to be strategic and data-driven, especially in this period of time where we don't have enough vaccine. And we want the process to be highly coordinated and transparent. I also want to mention that the distribution framework will be developed by the state, but we will be closely working with our partners in our local health jurisdictions on both network development and the distribution framework. Next slide, please. So what does equitable delivery of vaccines look like? All Californians, especially those disproportionately impacted by COVID-19, have equitable access to the COVID-19 vaccine, ensuring that all communities, urban and rural, receive equitable allocations of the vaccine, that we are engaged in significant education efforts focused on awareness, and we want to achieve high vaccination rates in all communities. So how are we going to achieve this? It's a big goal. So there's going to be a number of elements to the TPA arrangement that I want to highlight. The first is we are going to have pay for performance payments for vaccinating individuals living in the lowest HPI quartile census tracts. We're going to have payments to providers for vaccinating communities of color. We're going to have payments for targeted outreach and engagement efforts to ensure that our target communities are getting vaccinated, and also enhanced payments to facilitate evening accessibility, translation, physical transportation services, anything we can do to increase our vaccination rates in our various communities. Next slide, please. And with that, I'm going to turn it over to Paul Markovich to talk about Blue Shield's commitment to this project.
Thank you, Marta. I appreciate it. And I want to start by thanking everybody that's on the call. This past year has been the most challenging and stressful on our healthcare system and on our society at large that I've ever experienced in my lifetime. And despite those unprecedented challenges, I'm constantly inspired by the heroic efforts that I see every day from a whole range of organizations and people, whether it's our physicians, nurses, and hospitals, and everything that they've been doing to go to and beyond their physical limits to try and save lives, or frontline and emergency workers, making sure that we're getting access to critical supplies like food and keeping us safe and fighting fires. And I've had a chance to work with a number of public officials, state, county, local government employees who have been working pretty much nonstop for a year to try to cope with this pandemic. It's not meant to be a comprehensive list of examples, but I just wanted to say how thankful I am for all of you and the organizations and the people that you represent for truly inspiring heroic acts that we're seeing every day. I also know that all of this effort has taken a toll. You know, we're suffering from individual and collective exhaustion. We just want this to be over right now. And I think there's great hope in getting to that place with these vaccines. If we can just get a majority of Californians vaccinated, we have a chance to get back to something resembling normal. The good news is I think we have the basic elements to do that. We have a steady and hopefully increasing supply over time of vaccines, and we have a group of people in the healthcare industry, in government, and throughout our society and in communities that are obviously willing to make great sacrifices to make it happen based on everything we've seen so far. What we lack is a systematic process to bring all these pieces together and ensure that we're performing at an optimal level. And Blue Shield's been asked to put this process together and manage it on behalf of the state. And that's exactly what we're going to do. We're going to do it well, fast, transparently, but most importantly, we're going to do it with you. Because the only way to be successful with an overall vaccination effort is for all of us to play our role and do our part. It will certainly take a village to make this work. So I wanted to spend just a little bit of time up front talking about why Blue Shield is taking on this role and then how we plan to approach it. Bear in mind, I think this is our 6th day on the job, so we don't have answers to all of your questions, but we will get there soon. If we can move to the next slide, I just wanted to start with a few slides with an apology in advance. This is not meant to be an infomercial about Blue Shield, but I think there's some background about Blue Shield that provides helpful context. We're a nonprofit mission-driven organization. We are here to create a healthcare system that's worthy of our family and friends and sustainably affordable for everyone. And the best way we can serve that mission right now is to get as many people vaccinated as possible. And so that's exactly what we plan to do. The other thing we bring to the table, in addition to motivation to help, is that we manage large physician, hospital, and pharmacy networks across the state in all 58 counties. So developing and managing a network is, in fact, what we do every day as a part of our business. If we can move to the next slide, it's also true that we have a history of partnering with the private sector and the public sector on industry initiatives. Many of you probably know that I volunteered to co-chair the governor's COVID-19 testing task force last year. We managed to increase the average testing from about 2,000 tests a day to over 100,000 tests a day in a little less than 3 months. We also have worked closely with organizations like LA Care to establish a network of community centers available to everybody in the community, but targeted to the Medi-Cal population in Los Angeles. We've put $50 million into an effort. We've partnered with the Integrated Healthcare Association to try to do a common portal for physician credentialing. And we're working with the California Department of Education on our Blue Sky initiative to improve access to behavioral health. Again, not a comprehensive list, but just meant to say that this is a logical step for us to partner with other private sector entities like Kaiser, with the state, to try to make a difference in the community in terms of people's health. We can move to the next slide. We're talking a lot about equity, and I like to quote Ralph Waldo Emerson when he said, "What you do speaks so loudly that I cannot hear what you say." So I can talk to you a lot about equity, but I think what you're going to believe is what we do. And I just wanted to point out that, diversity, equity, and inclusion, just core principles to us. We work on them every day. We are not perfect, but we have been widely recognized for doing a lot of good work in this area, including being rated by Diversity Inc. as the top regional company for diversity. And we've had for several years running now no gap in pay between minorities and non-minorities at Blue Shield, or between men and women. So again, we have a lot of work to do still in this space. I am not going to go through all of these items, but in the spirit of what we do is what really matters. I wanted to demonstrate to you how important equity is to us as a principle. So that hopefully gives you a sense as to why we're here, why we accepted this challenge and welcomed it. If we can move to the next slide, I'd like to talk about what we plan to do and build off Marta's comments earlier. The biggest thing I think we can do is to create a performance management system. It's got to be rigorous and reliable and timely. We need to track all vaccines from order to injection. As I said to the team, if there's a truck on the side of the road with a vaccine in it just outside of Fresno, we need to know that. And these are such valuable commodities. They're so important that the only way to maximize performance is to know at all times what performance is. We have to understand who's getting vaccinated and to ensure that there's equity in that distribution and administration. We need to receive comprehensive, accurate, same-day data, and we need to report it in a detailed and transparent way. That's what we need to put together. And if you move to the next slide, it's not the only thing we need to do. Putting together that rigorous system, and Marta explained a little bit of what we'll need to change to make that happen, is baseline and foundational. But then we need to partner with key stakeholders, particularly on the ground in local communities, in order to be successful. We can build and we will build a high-performing network. But if we're going to achieve things like equity, just to give you an example, there's a lot of evidence and a lot of anecdotal stories about setting up sites in target communities of color, places that are higher risk, but having a lot of people drive from a long ways away to go to that site and receive a vaccine. So we don't consider it a success to set up a network that has sites accessible in target communities. Having a vaccine administered there is not success. Getting the communities that are the highest risk, that help us save the most lives, is success. And we need help with that. We can set up a high-performing network and we can manage it, but we really need the people who know these communities, that are trusted by them, who understand how to get people to believe it's okay to coordinate with them, to get them to access this network. That's where we're really going to be ultimately successful. And we are going to need to be creative and innovative and partner with a lot of folks, including many of you on this call, to make it work. We can move to the next slide, please. So what's happening now? We really talk about this often in 3 phases, and really it's just the first 2 phases that matter the most. The first phase is right now, nothing specifically is changing. We do not have this new process up and running or designed. So what's key right now is to keep performing at the highest level we possibly can. Vaccinate as many high priority people that have been determined through the prioritization process. Vaccinate as many of them as possible and report that data comprehensively and as timely as possible. And to just keep doing the best that we can with what we've set up at this point, and support the folks that are doing that work. That's the most important thing we can do right now in the short term. If we go to the next slide, the next phase we have to get to is we have to be ready to accelerate the rate of vaccinations. Our job is to, however much vaccine comes into the state, we need to be able to get it out there, get it into people's arms, have as minimal waste, hopefully none, but as the minimal waste we can possibly imagine, and ensure that people are getting vaccinated in the priority order that's been determined by the state. But we believe there's going to be more vaccine coming in the coming months. We need to be ready for it, and we need to have that infrastructure that I described to support making it work. Our game plan is to start introducing that new network later this month and to phase it in over multiple weeks. And so that's what we're hoping to do. Obviously, we're just in our 6th day. There's still a lot of work to do. So we're not giving quite definitive dates yet because we still don't know everything that we need to know. And we still haven't had the conversations that we need to have with all of you. Our plan is to sit down and have conversations with each of the local health jurisdictions and key stakeholders in that community to give input to what the network should look like and to develop that partnership and then introduce the network probably in different geographies in stages. So that's what you should expect next. That's what we're working on, is completing this design and then setting up that conversation and that dialogue. And with that, I look forward to working with all of you, and I'll turn it back to, I'm not sure exactly whether it's Dr. Pan or who's facilitating, but I'll turn it back over to the facilitator for questions.
I'll go ahead and jump in here, Paul. Thank you so much. Thank you to Paul and Marta for that presentation. And I want to start off by responding to some of the questions that have come up in the chat. So there are a couple of questions that come up. One is whether or not our dashboard is going to be able to report race and ethnicity data. And as another question by Mike Dark was asking the question about the uptake among staff and residents in long-term care facilities. There was a question about being able to, for consumers to be able to do that. Quick questions. So for, I'm going to ask really quickly, Dr. Pan, I know that we do have a plan to report race and ethnicity data, but that's still in process. Do you want to?
Yeah, I can start. I think it's absolutely, like, for example, in our California Immunization Registry and the other two registries, I believe that is a field. I think my initial understanding is like early on in the pandemic, there's a lot of missing data, but we are definitely working to report that as soon as possible. But I think we're going to also need to work on improved collection, and part of the new sort of data accountability, I believe, would be to improve that field as well.
Yeah, if I could add to that, yes, absolutely. That's going to be one of the areas that we incentivize through our structure, is ensuring that we capture the demographic details regarding the vaccinated population so that we can report with granularity regarding our success.
If I may just add one thing, and this would be a request on the partnership side. I watched the President Biden's team's presentation earlier this week, and apparently nationally, we're only receiving ethnic data on around half of the vaccinations. And so one of the things, we will have that as a field, we will capture it, we will report it, but we have to convince people that it's okay to share it. And that's where I think we could use a lot of help getting trust in the process.
Thank you. And so, you know, Paul, as you're building the system, right?
Yeah.
What it sounds like, what I'm reading in the chat and what I want to lift up from this conversation is that what we're hearing is that folks want to see data on, that includes counties, cities, zip code, occupation, certainly race and ethnicity. So those are a big care about, something for you to keep in mind as you all are building the system. I also want to speak to a question. There's quite a bit of chat about equity versus volume. Right. And this is something that I know that I have been fielding a lot of questions about in the press as well. Can you share with us a little bit more about your plan to engage with community health centers? We recognize that community health centers are the trusted source of care, especially for individuals who are uninsured. So for can you tell us how you're thinking about engaging with community health centers?
I think that was directed to me, correct? I just wanted to be sure.
Yeah, yes, yes.
Well, here's where I think, again, this is where the dialogue and the partnership is crucial, because here's where the tension point lies. These vaccines are incredible. They're also a highly perishable good, and they have to be stored at extremely cold temperatures. And once you pull them out, they don't last very long. And you don't want to waste them. And so in order to manage that really well and make sure we're not wasting this incredibly valuable commodity, we need to be able to work with a network that we're very confident can handle that, and can also make sure that they're administering pretty much all the doses, and that that waste is not there. At the same time, there's a number of situations where if you're going to reach these communities and make it work, you have to have a level of flexibility and feet on the ground and a lot more, local reach. And so somehow I think the part that I feel like we need the most help with is we can get these, we're probably going to need to work together to figure out where could these sites be, how could we use resources like at-home visits and mobile sites, pop-up sites, and work with people on the ground that really know that community, to make sure that we have a supply chain where we're not wasting any of this, but we're actually getting to those communities and vaccinating them. So I don't have a clear answer, except to know that that's the place, that's where the magic is going to happen if we're going to be successful, from my vantage point.
Thank you. I want to add to that comment, because I do think that there is often perceived that equity and volume are at odds with each other. And one of the pieces that I think is key for everyone to understand is that one of the things that California is also seeking to achieve is we're working with a recognition that, we've heard from the federal government that they consider the rate at which we are getting vaccines, into arms, administering vaccines as part of their allocation considerations. And so as we are thinking about, and again, I think that from the beginning of this process, equity has been at the center. And I think the fact that we are including pay for performance around equity as part of the considerations, part of the things that we are asking, holding Blue Shield accountable for and holding our vaccinators accountable for, I think is really key. But I also want to highlight how important it is that when the faster, what we're understanding is we're working under the belief that the faster we get vaccines out, the faster we get vaccines in. And when we talk about moving through our systems, right, and moving through our prioritization, when we talk about, how are we ensuring that we're bringing vaccine to the moving quickly through the groups that are prioritized so that we can get to the next group and the next group and the next group, so that we can make sure that as many Californians are getting access to vaccine as quickly as possible. We are working very, very hard to make sure that we can get those vaccines out the door. And I think that as what we saw from Dr. Pan put in the chat, that it looks like, in response to someone's question, it looks like for the next 2 weeks, we'll be getting a million doses. Is that correct, Dr. Pan?
Yes, that's right. So around between 500,000 and 600,000, those are first doses for new people. And then we're trying to get again away from second doses, but keep in mind, we need to catch up on the second doses for all the people that have already been vaccinated.
So that, and I just want to clarify, that's 1 million doses per week. Is that correct?
Yes. So 1 million doses for this coming week, 1 million doses for the week after, and it looks like 1.2 million is projected for the week after that.
So as we see that California went from, it took us 38 days to administer our first 2 million doses. It took us 8 days to administer our next million, right? And it took us 3 days to administer our next 500,000. And we've gone from receiving between 250 and 500,000 to 500,000 vaccines doses per week to next week, we're going to 1 million doses per week, right? What we see is that we have been, really moving, getting these vaccines out so that we can get access to vaccine to as many individuals as possible. But I think the point is made, right? And this is why we need to work very closely with our local health departments, whose bread and butter is caring for the safety net, right? To make sure that we are vaccinating our most vulnerable communities. And we're not just saying it's a nice to have, we are putting accountability, pay for performance, incentives, and contractual language around that to ensure that our most vulnerable Californians are getting vaccinated. So I just wanted to speak to many of those pieces in the chat. And if folks have additional questions, I can't go through every question in the chat because there's a whole bunch of them. So we'll take these down and respond, but I wanted to give a chance for folks to raise their hand. And Bobby, if you want to facilitate the rest of the Q&A.
You bet. Thank you. Well, we're going to start with Andy and then Diana and then Ronnie and then Andy Patterson. So Andy, go ahead. Introduce yourselves.
You mean Andy Imparato?
Andy Imparato goes first.
Yeah.
You bet.
Hi, Andy Imparato with Disability Rights California. Two questions. One for Paul. When you guys are capturing demographic data, I would strongly encourage you to include letting people self-identify that they have a disability or chronic health condition. I recognize that you're not going to get perfect data, but some data is better than no data. And then for the state, my question is, can we give a differential payment with an equity goal for folks that are affirmatively trying to find people with disabilities or high-risk disabilities to get the vaccine to those populations?
Thanks. I think that's a great idea, Andy. Let me take that back as we develop all of our P4P payments. My goal is to bring to you what that would look like, maybe at our next conversation. And so, if we can't do it here in this setting because of timing, because as we said, Paul said it was day 6 for him. It's day 8 for me. So, or 9. So we're all standing this up very, very quickly. So if we can't do it in person at a setting, that maybe we can get feedback electronically on that allocation criteria. So I think that's a really good one.
Great. Thank you, Andy. And thanks, Marta. Diana, and then after Diana, Ronnie, and then Andy Patterson.
Thank you, Bobby. Diana Tillotson Torres, Executive Director of the UFW Foundation. We really appreciate that the state's developing plans to accelerate vaccination and having a coordinated statewide practice process. We do have very large concerns about the federally qualified health centers not utilizing their capacity. We are seeing on the ground right now that different health centers are telling us that they're being provided very little doses from the county health departments. The San Benito Health Center in San Benito County, Central Neighborhood Health Foundation, which is in the Coachella Valley, had 0 vaccination doses this week. And we know that there is an allotment that's going to the local health departments, but we're not seeing that translated to the health providers that are focused on very vulnerable farm worker, rural, uninsured communities. In fact, we heard from the San Benito Health Foundation that they were reprimanded for using some of the doses for farm workers, and they were following the guidelines. So we're seeing that this is just a detrimental thing here, and we want to make sure that as you're looking at, volume capacity, what does that truly mean? And performance management, we need to ensure that we have a centralized way to reach farm workers. UCSF study shows that agricultural workers have the highest risk of death. And so we really want to ensure that there is a structured, intentional way to both allocate vaccine to agricultural workers, to the most vulnerable, and ensure that those are being administered by the most trusted partners on the ground, which don't tend to be large hospitals. It's the smaller community health centers and pilot projects with vaccinators who are willing to do mobile vaccination, which is really the strategy that's going to get us these most vulnerable populations vaccinated.
Thank you for those comments. I think that they're right on. And just to be clear, I view the community health centers and the federally qualified FQHCs to be a key partner. And I think that we should get folks on the network, and we are committed, and I would invite Paul to speak up too, to help get them on the network, especially if they're in strategic areas that can help us meet our equity goals. So absolutely, I see them as a key partner in network development, just as the county health jurisdictions will be as well. Paul, I don't know if you want to add.
Yeah, no, I agree with all of that. I think the only thing I'd say is, and this is where the dialogue is really going to be important, our ability to move quickly and ensure efficacy. It may be a lot easier to work with the FQHCs and the community health centers and put a testing facility right across the street that's just managed separately, but is done in coordination with you, than it is necessarily to have every single community health center and every single FQHC get trained on a new process. I'm not telling you what I think the answer is going into this. I'm just saying that I think they're clearly going to be, we're going to do what we can to make them a part of the network and make this a part of the process. But there may be other ways to solve this problem that allow us to both have the performance at the statewide level that we were just talking about and partner with the community. So we'll figure that out together.
But I do want to commit to the ongoing dialogue with our colleagues.
Absolutely.
Yeah, we'd appreciate that.
Thank you, Diana. Ronnie, it looks like you put your hand down. Do you still want to make a comment?
Yeah, I do. I was just helping you. So Ronnie Kelly, County Behavioral Health Directors Association. I think most of us would agree that the state needs some assistance. So I think this is very exciting that we're moving in a direction. But knowing that many of our high-risk populations for severe or for mortality from COVID are really off the grid. They live in poverty. They are uninsured. They are populations like those I represent who have serious mental illness or addiction who do not go to a network of physicians, those people who are without homes. Those groups, we've been all working to try and target them specifically in our current system. So is this the Blue Shield TPA in addition to, or is this going to be instead of the current way we're distributing?
So we are centralizing the distribution, but many of the network providers that are currently in the county-based system, we will credential for the new statewide system. So there is a change. I don't want anybody to misunderstand that we are transitioning to a state decided allocation system. However, we're going to build on the network that's already been created that can deliver the vaccine to our various communities. And provide the P4P payments that incentivize that delivery system. But I'm also not going to promise that every single provider that's in the current network is going to be in the network in the after condition. I don't want to make a false promise. So, but we are going to work closely with our county health partners to get those providers that can reach those key populations, just like the ones you described. Those are the ones that I have heartburn about, that we can make sure we get vaccines in those folks as quickly as possible so we can save as many lives as possible.
Thanks, Ronnie, and Marta, thank you. We have time for one more comment, Andy Patterson, in this section of the agenda. So I know many of you have many other comments to make. If you could put them in the chat, we will record them and make sure that not only do you get to see them, but Marta and Paul will get them as well after the meeting. Andy?
Great, thanks, Bobby. So I contextualize my comments with, I know everybody who's at the state and on the ground is working so hard, so many hours, and is trying their best in an impossible situation. And we're not going to be perfect in any of this. And so kudos to all of the work and the recognition quickly that we have to change systems. We're supportive of that. I'm with the Community Health Center, CBCA. But I've been trying to be as patient as possible and have been so excited and supportive of the Newsom administration and all his commitment to equity and the team that he has brought in and all of that. And they're great people, but we're starting to not see action on the equitable. We're just talk about equitable all the time. And health centers haven't been as strongly as part of this network and the conversation as we needed to be. Health centers were created specifically for equity. We were put into locations for equity and to build relationships and trust. And now they serve 7.4 million people in California, 1 in 3 Medi-Cal beneficiaries, 1 in 6 Californians. They have built a legacy of trust, and they have refrigerators, they have teams, they know how to do vaccines, and we haven't been leveraged. The Biden team has a whole plan on FQHCs as partners, and we still haven't been leveraged. We cannot, volume and equity are not equal things. And it might be messy. Equity is messy and it's slow and it takes onesie twosies across. And we think our main point is that every single FQHC or health center community clinic should be able to contract with the TPA and should receive an allocation, even if it's slow. I certainly am not discounting, Paul, your point about a clinic across the street and if it's coordinated, but centrally, we have systems in place. They're not as pretty and they're harder to work with because we're not under one corporate head, but we're here and we know how to do it. We just need the resources and we need to be brought into the conversation. So really looking forward to it. The health centers really want to lean in and our doors are wide open to how to do that. Thank you.
Thank you, Andy. And I'll turn the mic back to Dr. Pond and Dr. Burke-Harris.
Thank you so much, Bobby. And now we're going to go ahead and move forward to hear the updated recommendations from the drafting guidelines work group. For that, we will have Dr. Rob Schechter and Dr. Oliver Brooks, who are the co-chairs of the drafting guidelines work group. In transitioning from an age and sector-based approach to a more age-focused approach, it was really important to us to continue to use this 3-part framework by engaging all of you as members of the community so that we could hear your input and share your questions and concerns with the drafting guidelines work group. We have shared all of your, we've been very grateful to receive all of your input and concerns, and we've shared this with the drafting guidelines work group. So now I'd like to turn it over to Dr. Schechter and Dr. Brooks to report on their findings and recommendations.
Thank you, Dr. Burke-Harris. Bobby and group, can you hear me okay?
Yes, we can.
Yes.
Thank you. Good afternoon, everybody. And again, a privilege to be able to talk with you about what's been going on at our work group. In the aftermath of some of the changes in the guidelines, there were questions coming from you and from the public about where some of the groups were prioritized. So the state has brought to the work group the question of specifically questions around where in the prioritization now are persons with underlying medical conditions and persons with disabilities across a spectrum of disabilities. To try and inform the conversation, the guidelines work group reviewed available information on the risk in these groups with the understanding that in combining all of those with medical conditions or combining all of those with disabilities may overlook higher or lower risks within the group for specific individuals. Next slide, please. So as a quick recap, for our national recommendations under the Federal Advisory Committee of Immunization Practices, persons with high-risk medical conditions and disabilities are categorized in Phase 1C and represent, because of how common some of these high-risk conditions are, constitute a large proportion of the population, whether nationwide or statewide in California. Next slide, please. To as well as looking forward to these groups, again, revisiting the risks in those with medical conditions or disabilities. We also looked at the groups that have been prioritized so far, and again, the data around risk by age, which shows up again and again as a strong risk factor for severe, including fatal COVID-19 disease. So this data from national statistics shows the tremendous increase with advanced age and risk of severe fatal disease. In this case, fatal disease with those starting at as early as middle age, but especially age 65 and older, and at age 80 or 85 plus, tremendous increase in risk. Next slide, please. And this graph, which I think we've shared before in this committee, shows compared to 18 and 29-year-olds age-related risk either for hospitalization or death, and again, the risk increasing starting at 30 years, but much more so at 50, especially at 65 and older, as the basis for the discussion and the prior discussion around prioritization, the inclusion of that risk group in national and state prioritization recommendations. Next slide, please. So with that as a point of comparison with 10-fold or even 100-fold risk in advanced age, the working group also looked at other risk factors. In this case, this is CDC data on risk by race and ethnicity. And depending on the group and the geographic setting over the course of the pandemic, somewhere in the range of 2-fold to 5-fold risk of either hospitalization or death in Native populations, African American populations, or Latinx populations. Next slide, please. So then going back to the underlying medical conditions and looking at some of the available data nationwide on risk by particular underlying medical conditions. And there's lots of numbers on this slide and a little bit of an alignment issue, but the point here being that if it's severe obesity or chronic kidney disease, the CKD midway in the chart, up to 4-fold risks in mortality from the specific underlying conditions with available data. This is hospitalization related data, and for other conditions, risk anywhere between a similar risk to other populations for, say, COPD in this one study, for hospitalization, higher in other studies. But within this 3-fold risk overall, on the bottom line, a range of somewhere between 1 to 4-fold risk of hospitalization or death in various studies. Next slide, please. And going back again to national and CDC related data, that on the top in the red box, you can see age-related effects. In this case, again, it's hospitalization or death in those hospitalized. So for those who are hospitalized at these age groups, what was their risk of dying? Up to 11-fold for the oldest in our society. And then comparing that to gender or disease-based risks of death, and this data from early on in the pandemic. Next slide, please. Again, within these average risks, there are differences in risk by condition or other factors. In this case, those with multiple conditions, the most frail and fragile, with multiple underlying conditions at extreme risk of severe outcomes from COVID disease. What's difficult to tease out in this slide is the role of age along with these conditions, and that most of these severe illnesses were occurring in the oldest members of society. Next slide, please. So then shifting from persons with underlying medical conditions to persons with disabilities. This is one of a few studies that were reviewed by the work group in its recent discussion. This is data based on COVID illness, which is the column that says cases or case rate in the middle of the middle columns of the slide. And then over on the right-hand side, there's a fatality rate. So looking at COVID illness and COVID death, comparing Californians who are not currently receiving disability services, IDD services, with those who are receiving services, but this is broken down by various settings of care or residence. So again, apologize, there's a lot of information on this slide, but focusing on the case rate column towards the middle and the death rate column on the right, the work group was reviewing this data in terms of comparing those who are not receiving services, so average rates statewide, along with those receiving services, and thinking about the congregate settings or residential settings that are already eligible for receipt of vaccine under the Phase 1A guidelines for care facilities for those who are older or medically frail. And so if we look at the very bottom in skilled nursing facilities, had the very highest rates of case rates and death rates. Those in ICFs, our community care facilities, at progressively lower rates, but still increased over the rate of the death rate of 41 per 100,000. And then in contrast to the increased rates for those being cared in congregate settings, in this study, those who are residing in their own home or family home, while there certainly were cases and deaths in these persons, that the rates were lower than those even in congregate settings, or lower even than those on average who weren't receiving services. Next slide, please. The work group looked at two additional studies, one on claims data nationwide, done by Dr. McCarty at Johns Hopkins, and a data on rates and disabilities in the United Kingdom, which both indicated a 2 to 3-fold risk of mortality in persons with disabilities compared to those without. In the UK data, 90% or so of the persons who died with disabilities were 65 years of age. And in both these studies, there was limited data to distinguish whether persons with disabilities would also be considered as persons with underlying medical conditions based on having multiple conditions. So towards the second bullet from these other two studies, it's challenging to assess what the risk is for those who are currently excluded by the current immunization prioritization guidances. What is the risk for those under 65 years of age? And what is the risk for those residing outside of congregate care? In contrast, the data from the California study, again, suggested a decrease in average risk to those residing outside of congregate settings. And so it led to discussion by the group of how much of this observed risk, this 2 to 3-fold risk of mortality, also reflects additional underlying medical conditions that would be so the persons who would be eligible under their medical conditions would qualify under that category as well. Next slide, please. So now I'm going to hand it over to Dr. Brooks and appreciate your attention. And again, I think speaking on behalf of the work group, certainly are aware of the concerns of those who've asked this committee and the state about where are they in the prioritization scheme and how valued are their lives and their concerns. And the work group is certainly taking those concerns seriously. And with that, I will pass it over to Dr. Brooks.
All right. Thank you, Dr. Schechter. And thank you, Surgeon General Burke-Harris and Dr. Pan for chairing this Community Vaccine Advisory Committee meeting. So the workforce, the drafting guidelines work group met, and this is what we came up in synopsis, summary fashion. So phase 1A, continue and complete the immunization of healthcare workforce individuals and those that reside in long-term care facilities or adult assisted living facilities. That is clean, that is where we are, and that has not changed. Now, in terms of phase 1B, tier 1, first of all, Dr. Schechter presented very compelling evidence as to why you would focus on those 65 years of age and older. There's a much higher incidence of hospitalization and death. So in looking at that, we did agree to immunize individuals age 65 years and older, and or those working in essential sectors of agriculture and food, education and childcare, and emergency services. These were the 3 essential worker subgroups that had the highest risk, in our opinion, for having societal impact if they're infected. They're out there, they're in the front, they're exposed. They may have some effect on the economy. And then looking at the bullet 3, they also are part of an equitable allocation and distribution of the vaccine. So with our foundational principles of safety, transparency, and equity, which we have been working with from the beginning, this is what we found in phase 1B, tier 1. Next slide, please. However, it is clear that there is still more to be done. And we've heard from other groups, we saw the data that Dr. Schechter just presented in terms of disability, underlying medical conditions. So that goes beyond age. And so this is the next group that we're looking at after those we just referenced in the 3 essential worker categories in 65 and older. So individuals 16 to 64 years of age with underlying serious medical conditions or disabilities that increase their risk of developing severe COVID-19, and you saw the data. So underlying medical conditions or disabilities. So we know that that's not as easy to determine like at a large vaccine setting. So this applies to settings such as healthcare systems or other clinics, but not mass clinics or other local health department clinics. And it applies where the underlying conditions or disabilities can be verified through access to medical records. The qualifying health conditions and disabilities need to be defined with sufficient specificity that eligibility for this phase can be determined when the patients request an appointment for the vaccine. Implementation plan should include outreach and assistance, which you all have mentioned and we've heard from you, to individuals who have barriers to making appointments for vaccine or access to the vaccine. And these groups are prioritized after phase 1B tier 1 due to their large numbers and competitive aggregate risk of severe outcomes. So this is why we really feel they are that important. And then there is an alternative proposal that limits eligibility to individuals with multiple, either, for example, greater than 3 underlying conditions. That was raised also, because as you saw from the data that Dr. Schechter presented, have a very, very high rate, more than 80% of the deaths. Now, we do acknowledge the local health departments have emphasized their crucial role in immunizing residents and local correctional facilities and homeless shelters. and I will add to that detention facilities. So we're looking at the local health departments to manage and immunize those 3 areas: correctional facilities, homeless shelters, detention facilities. I would say that hearing what Blue Shield is to deliver for the state is encouraging, with their desire to ship directly to the vaccinators, to be working on equity, to document race and ethnic data, and to have real time, the way it looks, data going forward in terms of who's receiving the vaccine, in terms of the sites, and who is getting vaccinated. So I'm going to stop here and just ask Dr. Pan, the co-chair of the CVAC, to make any comments at this point.
Great. Thank you very much, Dr. Schechter and Dr. Brooks. And thank you again for your leadership of the drafting guidelines work group. So as you can see, sort of from this important conversation, I think we've heard from many of you, and again from our drafting guidelines work group and the implementers, and essentially we are taking this incredibly seriously, and this is the next priority group. I wanted to highlight some language that's discussed, but I think we're still sort of, as mentioned here in one of these bullets, I think all of these conditions and disabilities need further definition, and really importantly, methods to really do this in an equitable way. And this is all part of, again, access and equity. And inclusion of this is, not only sort of the higher risk for hospitalization and deaths, but really thinking about, again, equity and access. So some of the ways we've talked about defining a developmental or high-risk disability would be if an individual is not only likely to develop severe life-threatening illness or death from COVID-19 infection, but that acquiring COVID-19 would limit the individual's ability to receive ongoing care or services vital to their well-being and survival, and that providing adequate and timely COVID care would be particularly challenging as a result of the individual's disability. So those were some things that are being discussed as well. And I think really the outcome is that the Secretary Galley and Secretary Richardson have directed us to have a group, a vaccine implementation group, to really take a deeper dive into these really important issues, and hearing also about how, again, to make sure this can be implemented, because we've heard equally, as you just saw, some concerns about how to operationalize this. So it is sort of the next priority to do, and there's going to be, again, a group convened, and vaccine implementation group around these individuals, helping to further define this group. As far as the definitions as well, the drafting guidelines work group, will be taking a closer look as well at sort of within chronic kidney disease, for example, what level is that, and how do you define severe diabetes mellitus. So this is going to be a planning process, though, and where we can create a network of providers to ensure that we are addressing accessibility for people with pre-existing conditions, so of all disabilities. And we really want to get this right. So again, I think what we've been learning over the first few weeks of this vaccination campaign, and as you've been hearing about over the course of this meeting as well, is we want to plan well and get it right to operationalize it. So that's what this this meeting will do, and it will start this Friday. And actually, Kim McCoy-Wade, the director of the Department of Aging, will be helping to lead that group, and wanted to briefly introduce her to all of you to say a few words about that group that will be convened this Friday.
Thank you, Dr. Pan. I will really be a few words because first of all, just want to thank all of you and all of the committee's work that really teased that up. I'll be joined by Director Nancy Bargeman from DDS and Director Aragon from CDPH in supporting our secretaries, Secretary Galley and Secretary Richardson from GovOps in this work group. And I want to thank the representatives from the disability community, the aging community, and other stakeholders, the medical community and labor, who will be joining us in that group. So we will begin our work at the end of this week and address recommendations and advice on the who, the when, the how, and the where, really get to brass tacks on how to operationalize equity and really make it real. So more to come, and thank you for those of you who are willing to roll up your sleeves and get to work with us.
Great, thank you very much, Kim. So again, we want to just highlight that this is sort of where we've been, where we are, and where we are moving forward. I see some questions in the chat as well that again, we want to make sure we're attending to this group for sure. And then there still is the intent to move to an age-based framework, but we want to get through sort of where we are, and then do the planning of those next steps, and then be shifting and pivoting to the age-based framework that we've discussed. And we do, as we are hearing more again about supply, we're hoping to really work towards mapping out when we think we can get to each of the next steps, and being able to do that in the near future.
Erica, may I add one quick thing? The
Please, yes.
drafting guidelines is here represented, and we're listening to what your input will be, and we will be meeting on Friday to take in your input to parse out and detail out what the final recommendations would be that would be submitted to the governor.
Great. Thank you so much, Dr. Brooks. All right, with that, I think we can take any initial questions, and why don't we start with that? Bobby, I'll let you facilitate.
Okay, thank you, Erica. We are running up against the clock, so we're only going to have time for a couple of questions in this section. So we're going to start with Aaron and then go to Ron Fong, and then we'll see where we are. But just know that we'd really appreciate your comments in the chat if you don't have a chance to speak verbally. Aaron, please introduce yourself.
Hello, everybody. Aaron Carruthers from the State Council on Developmental Disabilities. Really want to acknowledge and thank the amount of progress that's been made on this issue that's been released during this call. Surgeon General Burke Harris, we want to thank you for leading off the conversation at the beginning of the meeting by acknowledging and stating that disability is part of the state's equity framework. Dr. Pond, thank you for coming to the State Council's meeting last week to state the same. And Dr. Brooks and Dr. Schechter, thank you for the presentation of how to take the science and thread the needle for a solution forward. There's clearly a lot of work and dedication and commitment to this, and responsiveness to what we've been raising on these calls and these meetings. So thank you for that. The proposal that was presented, I think it is the best attempt to thread the needle based on the science. It's very complicated. It's very confusing. I think it'd be very difficult to implement. So one suggestion off the top is I really think developmental disabilities needs to be named in the list among people with disabilities and those severely impacted by COVID. But developmental disabilities specifically needs to be named. But I'm looking forward to the work groups where we can roll up our sleeves and figure out how to make this really functional. So thank you.
Thank you, Aaron. Let's go to Ron Fong.
Thank you, Bobby. Ron Fong, President and CEO of the California Grocers Association. Thank you to Dr. Brooks for reaffirming Tier 1B. There's some confusion as to where 65 and older lie, whether they're a priority or not. And I remember that we had a whole meeting about 65 and older not being prioritized over Tier 1B, and that seems to be reaffirmed. Yet we are seeing counties, in particular Sacramento, Solano, and Placer, that are prioritizing 65 and older ahead of Tier 1B essential workers. And then they are also prioritizing the essential workers groups over another, grocers being last. So wanted to see if anybody had any clarification on how counties are able to do that, or if they should be able to do that.
I can take a stab at a response, and I again hear and understand your concerns, and I think just reflecting back on my opening comments, I think we are in a transition phase right now, and just back to the numbers, which was part of my other role, we have around 3 million or so that are eligible in Phase 1A, and the current Phase 1B Tier 1, including 65 and older and those three sectors, and grocers are included in the food and agricultural sector, is approximately 8.5 million, I believe. So that's 11.5 million people that are eligible, which means we need 23 million doses. I think I explained to you we've received about 6 million doses. So we are in this transition phase where we have said that, that in Tier 1, Phase 1B, that those groups are equal. On the other hand, when you get, again, it all comes down to the devil's in the details. If you're trying to operationalize that and trying to, again, be, as efficient as possible, I think different counties there's two things that I think are occurring. One is that they had plans in place before sort of we at the state pivoted our direction. And two, again, I think really trying to operationalize this is extremely difficult. And again, extremely challenging decisions that people are making. But again, that's where we are. I think it's going to take us a bit of time to get through that 8.5 million people, and we've seen some early data as well around hesitancy. So we want to work with all of you on that part as well to improve our uptake in the various communities. I do think as we look forward, we will likely be, I think we're thinking about this as like a rolling eligibility. So we're not going to absolutely get through each phase before we start the next group, but we also want to, make a good dent in it. So I think that is what you are seeing. There is some variability, but that is, on the other hand too, I think that's the other direction we're going as far as more centralization, more equivalency across the whole state. And that's the challenge we're in this transition phase.
Thank you, Erica. We have time in this section for one more comment, Christina. Christina, we can't hear you.
Can you hear me?
Now we can.
Can you hear me?
Yes.
Yes.
Thank
Yay.
you.
Okay, great. Sorry, I've been having microphone problems. This is Christina Mills from the California Foundation for Independent Living Centers. I echo all of Aaron's thanks to everybody, and I know we've had several email and phone conversations about folks with disabilities and those with underlying health conditions. I can tell you that as a person with a disability who has multiple underlying health conditions that would qualify me, I don't feel confident that even the best primary care doctors would actually be able to give me the documentation that I need to get qualified for a vaccine. So that's very concerning, number one. Number two, I know that we have been really pushing for both regional center clients and for those that have HCBS waivers. I'm curious to know why only the IDD population was taken into account. Three, I really do feel like the standards that were put in place were not recommendations that we've been providing.
Christina, we lost your sound again.
Oh, can you hear me?
There you go. Yeah.
Thank you. Sorry, it's this USB mic. And three, I don't think that the recommendations posed are in line with what we've been suggesting as a group.
We lost you again,
Fourth,
Christine.
And fourth, I really, really want to emphasize choice for people with disabilities. I want to have a choice, if I'm qualified for a vaccine, to go to a site that is going to be best and easiest for me to get to. And knowing that my doctor's office can be very hard to get an appointment in, if it's faster for me to go to another site by public health, I want to be able to go to that site. Thank you.
Thanks, Christina. Dr. Pond, I think you wanted to make a comment, and then we're going to have to move on to our next topic. So I encourage everyone that wanted to speak verbally to put their comment in the chat, please.
I'll just be really quick. I did see it, and I know it's been a theme and one of the recommendations. So we are working on how to address high-risk congregate settings, so including our incarcerated settings, homeless shelters, other high-risk congregate settings. So I think it'll be part of our equity framework as we work with the TPA and think about incentives and other things, but it's still in the works. So we will return back with more detail to you the next time.
Okay, Dr. Burke-Harris.
Thank you. So now we want to move forward to how we're using equity as we move forward. And if we could go ahead and bring up the next slide. So if you all will recall at our last meeting, we talked about, and I presented information about what it would look like for the state to utilize a categorized prioritization system that included a database tool to calculate how we distribute a scarce resource equitably. Next slide, please. And, as we've heard on this call, and it's been reiterated, is it's critically important as we move forward to address both equity and simplicity so that we can move forward in getting vaccines to the communities that need them. And so one of the tools to be able to do that is a categorized priority system. It's currently being used in Massachusetts, Tennessee, New Hampshire, and I believe in consideration in Rhode Island. And the example that I shared at the last meeting that I want to reorient you all to is the example of potentially having 80% of vaccine supply being allocated according to the current methodology, and 20% of the vaccine supply that could be allocated to counties or regions that has the lowest HPI quartile zip codes. And that can be zip codes, it can be census tracts. There are different ways that that determination can be made. Next slide, please. And so if you'll remember, just to refresh, this is a slide that we shared last time about the categorized priority system, around how that might work. And we got lots of questions about it. So if you'll move to the next slide, please. What we tried to do today is just to simplify a little bit, to have a clearer sense of how we can use equity in our vaccine allocation, right? So for example, so this is another way of depicting what I just showed in the last slide. If you will see, 100% of vaccine doses or that is going to a county or a region, if you break that into 80-20 and allocate the 80% as it typically would be allocated, right? And so 20% would go to the first quartile, highest HPI quartile, 20% would go to the second highest HPI quartile, 20% to the third highest HPI quartile, and 20% to the lowest HPI quartile. And then take that remaining 20% and allocate that to the lowest HPI quartile, which would be our most vulnerable communities. What this shows is that the aggregate distribution to the lowest HPI quartile would end up being 40%. And what the goal there is try to look at the data around where are we seeing the greatest number of cases and the greatest number of deaths, and to really try to use this equity framework of understanding that of how we bring doses, a proportionate amount of doses, to the communities that are most vulnerable and who are experiencing the greatest impact as a result of COVID-19. Next slide, please. And so when we look at our tools to address equity, we want to highlight one tool is allocation, and a categorized priority system is one of the tools that we're looking at to be able to do that. We heard again about outreach to targeted populations. We heard about, you'll hear more later in this meeting about earned and paid media that is powered by research about how we reach vulnerable communities and how we ensure that we're addressing reasons why certain communities don't have as much vaccine confidence as others. We talked about partnering with community-based organizations, both in outreach and communication, but also, as we talked about as well, as we heard from Marta Green earlier in this conversation today, really to help to ensure that folks, getting folks to their appointments to actually get their immunization. So really in the implementation. And some of the tools that we have that we're seeking to deploy around that include, as we talked about, incentives, support, accountability, pay for performance, right? And when we're talking about, vaccine administration in our low HPI communities, to our vulnerable communities in pop-up clinics, transportation services, and in-home services. And there was a question previously in the chat around why would we incentivize providers, or why would we incentivize providers in the TPA to provide vaccination doses to vulnerable communities? Shouldn't they just be doing it anyways because this is health and this is what we do? And what the state of California is seeking to acknowledge is that, you know, as we talked about when we first began this process and first talked about looking at equity and what does it mean to operationalize equity, it's a recognition of the historic and structural barriers that exist that make it more difficult for these communities to have the same access to vaccine. And so we do have to incentivize and do pay for performance if we want to get equivalent outcomes in vulnerable communities that face greater obstacles. And part of the reason why we've looked at the Healthy Places Index is that the Healthy Places Index is targeted. It's an index that looks at what are the resources that communities need to keep themselves healthy. Access to transportation, access to education, how many healthcare centers are located per capita in a community. And unfortunately, because of the history of racism and discrimination in the United States, what we see is that those community resources are not evenly allocated. And that is part of the reason that gives rise to the differences that we see in health outcomes, in vaccination rates. And if we want to acknowledge the structural factors that make it difficult for vulnerable communities to get equivalent, to achieve equivalent outcomes, we have to provide support for our for healthcare providers in our vulnerable communities to be doing this outreach, right? Because we have to recognize that many of these communities have been underinvested, and we also have to provide resources. And while we're doing that at the same time, we have to require data and accountability. So if we go to the next slide, I just want to refresh the slide that we saw presented by Marta Green around how will California track and achieve equitable vaccine delivery, right? And highlight that we do pay for performance in lots of different fields, right? We do pay for performance across industries. We're doing pay for performance on equity, right? So we're doing pay for performance for vaccinating individuals in our lowest HPI quartile census tracts or zip codes. We're still operationalizing that piece. We're giving, we intend to give payments to providers for bringing vaccines to communities of color, payments for targeted outreach and engagement for reaching hard to reach communities, and enhanced payments to facilitate accessibility with the evening hours, translation, physical services, et cetera. And that is really, these are some of the key tools that California is deploying to bring equity to the center of the work that we are doing. And so I'll pause there so that we can, for any questions.
Great. I know Jake Snow had a question about the census tracts versus the zip codes. Jake, maybe you want to just comment on your question about the Healthy Places Index.
Yeah, thank you. Jake Snow, I'm an attorney at the ACLU of Northern California. And Dr. Burke Harris said that that's still being operationalized. And so just request an answer on that. I see that there's a little bit of inconsistency in the slides with respect to whether the HPI will be calculated by census tract or zip code, and wanted to know that detail. So thank you very much.
Thanks, Jake. Melissa, did you want to comment on this topic? Melissa Stafford-Jones?
Yes, thank you, Bobby. Melissa Stafford-Jones with the First Five Association of California. I do have a question. I'm wondering if we can link the helpful remarks that Dr. Burke Harris just provided in the prior discussion, which is, can you help me understand how the current status of phase 1B tier 1, which as Dr. Pond explained, and I think we all understand, there are more people than current vaccines. So there's, challenges in terms of how to operationalize that, and how will equity be incorporated into that part of the decision making and rollout and operationalizing of phase 1B tier 1. I think just as an example, we saw some in the chat box around farm workers and sort of how that's impacting, from my perspective, thinking about childcare workers. We know there are significant issues there as women of color, and that it's affecting other women workers of color who are not able to access childcare necessarily. So I'm trying to understand the linkage there with the phase 1B tier 1, operationalizing that with this equity discussion. So any insights or reflections on that would be helpful.
Sure, I'm happy to comment on that. I also, Dr. Pond, I know you look like you had something that you were going to say as well, but let me go ahead and respond to this question first. So as I think we've talked about in previous meetings, but I want to reiterate, when the drafting guidelines work group first developed a framework that was based on, in part on age and in part on sector. Part of the reason why they had this framework was as one way to operationalize equity, right? And so having that sector framework, and particularly when we look at the prioritization of, for example, farm workers, childcare workers, that was one way of doing that. And as we as a state recognized that we needed to move from a sector and age-based framework to a more strict age-focused framework, the determination, which you all heard announced in previous weeks, was that we're going to complete tier 1 of phase 1B, and then we will move from there to an age-based framework. And so that is what the state of California is doing. Part of the consideration of completing tier 1 of phase 1B it included this consideration of equity and this recognition. Number one, there were many counties that had already begun implementing tier 1 of phase 1B. And, but really that consideration was a part of it. And then in addition, this recognition of as we were moving to a more age-based system, recognizing that the allocation of vaccine to our more vulnerable communities would be an important aspect of being able to address equity while moving to a more age-based framework. So in response to your specific question around how was equity considered, equity was very much considered in thinking about, for example, we know among our farm workers, we have among the highest rates that we're seeing, especially in the Central Valley. When we look at cases, hospitalizations, and deaths, we know that our Latino population is disproportionately impacted in California. And when we look among our farm workers, right, we see that, that was, especially in the Central Valley, this is where we've been seeing very high case rates. And so that was part of the consideration about completing that tier before moving to an age-based system. Does that answer your question?
Thank you. I mean, I think, yes, I think that I really appreciate all the thought and the centering of equity that went into the creation of phase 1B tier 1. I think, candidly, I think we're all wrestling with the reality that even within phase 1B tier 1, we have more people than we have vaccine, and that at least at the local level, as it's rolling out and operationalizing, I think we're not quite seeing yet the path to reach some of the groups we've all agreed from an equity perspective it's really important to reach sooner rather than later. So I think it's just a really challenging time that we're all trying to work through and really think about how do we keep making progress on all these fronts that we know we need to, that's so critical for all the reasons you just articulated. Thank you.
Yeah, I want to highlight that's also part of the reason why we're moving to a third-party administrator, right? Is to allow us to be able to use some of these contractual tools to which, you know, and it takes time for us to do that. But again, to be able to utilize allocation, outreach, pay for performance, incentives, that's part of the reason why we're moving towards a third-party administrator, to be able to have stronger tools by which to operationalize equity.
Thank you, Dr. Burke-Harris. I think we have time for one more comment before we're going to take a break. Kieran, do you want to go next?
Yes, thank you. And I'll be quick. And I first want to say thank you, Dr. Burke-Harris, for sort of laying out the history of structural racism in our communities and in this country. I think it's just really helpful to hear that framing over and over again, because it's so important that we understand that in this conversation. My question is really if you can help us understand sort of moving from what we were talking about before, which was a minimum allocation of doses to our lowest quartile HPI zip codes, moving from that to this pay for performance. I'm sort of unclear about why this is better or why it will be more impactful and how we made that decision. So I'm hoping you can just help us understand why we're changing how we're going to target those zip codes.
So Kieran, I want to, Bobby, can you put up my last slide really quickly?
Sure.
Because if I understand your question, it sounds like, why are we moving away from greater allocation to, no?
No, why are we going to pay for performance instead of just having a set amount of doses that are, because when you say pay for performance, what I'm understanding is we'll offer providers the option to really target those areas, those neighborhoods, those populations, and we'll give them financial incentives if they do, which to me sounds different than what we were talking about previously, which was saying 20% of our doses will go to those zip codes. Like, it's a little less clear what the outcome will be. And so I'm trying to understand what you see as the difference between those two approaches, if any, and why we're going with pay for performance now.
Bobby, can you go back to, thank you for clarifying your question. Can you go back to the previous slide before this?
Sure.
So when I say tools to address equity, what I mean is, so when we have a third-party administrator, the state allocates where the doses go through the third-party administrator. So when we're talking about having, using the data to say these communities have higher rates and higher deaths, and we know that part of that is because of the history of structural racism and the obstacles that have been put in, and third-party administrator, you need to allocate for whatever the percentage that we end up with, X% of doses to that lowest quartile HPI. That's one part of the contract that we're going to hold them accountable to. The next part, you know, we're doing the outreach. You're going to hear about the earned and paid media. We're going to hear about, and when we say partnering with community-based organizations, that's another part of the contract that we're going to hold them accountable to. This is not a nice to have, this is a must have. When we say incentives for supporting and pay for performance, what we're saying is, and this is, I want to be clear, this is really important. When you remember Marta said at the beginning that this is, it's a cost basis. So the third-party administrator, they get the cost for doing it, but they don't get to make money off of it. The pay for performance is not from the state of California to the third-party administrator, right? The pay for performance is from the third-party administrator to our vaccinators on the ground, right? To say, hey, you guys, we're trying to hit these targets. You need to, we're going to incentivize you to vaccinate folks. And so this is, these are ands. These are not ors. This is allocation. Yeah, we're gonna do that. Outreach, we're gonna do that. Media, we're doing that. Pay for performance, we're gonna do that. All of these are necessary because achieving equity, that's not something that's easy. It's very, very, very hard to do. We know that these structural barriers are entrenched from centuries and generations. And so when we say we in California are making a commitment to equity, we are using all the tools in our toolbox to get us there. Bobby, you can go ahead and take that slide down.
Okay, great.
And with that, it is 5:05. It's time for a break. Very grateful for you all. We will reconvene at I'm gonna
5 minutes.
5 minutes, 5:10. We'll be back at 5:10.
Stand up quickly and stretch.
Encourage everyone to get some water, practice some self-care, stand up if you're able, and otherwise stretch out in anything that'll get your circulation going.
And you can just turn your cameras off and go on mute and come back.
I know that was a very short break, but it is 5:10. So if folks can turn their cameras back on so that we can resume the meeting, that would be great.
Okay, I think we're ready, Dr. Burke-Harris.
Thank you, Bobby. And so now moving forward, we're going to talk a little bit more about community engagement, equity, and vaccine acceptability, and continue that discussion. I'm pleased to reintroduce Marisela Rodriguez from the Office of the Governor, as well as Marcela Ruiz from the California Department of Social Services, and Martha Dominguez, as well as Dr. Arlene Brown. I'm sorry, Dr. Martha Dominguez, as well as Dr. Arlene Brown. Marisela?
Hi, can you hear me okay?
Yes, we can.
Okay, and I may be talking really fast because I'm running against the clock with my son in the background who may need help in a second. So just appreciate the conversation on equity and the work that we're doing as we move forward. If we can go into the next slide, what I wanted to do was just give a quick overview of what you're going to expect out of this presentation. One is that as the state ramps up our efforts on vaccination, we want to give you a quick snapshot on highlights on just some of the work that we've been doing so far. And then an update on our community engagement, since we know that working with trusted messengers is going to be key, giving you a quick update on that. And then as we ramp up, we also want to ensure that we're continuing to address issues of hesitancy and really creating content with an approach that is about cultural humility. And so we're going to give you some research insights on that, and we'll go ahead and get started. So next slide. So this slide is really quick. I'm not going to go into each detail, but wanted to give you just a sample of the performance on our digital work. The bottom line here is that our assets, our content that we have on digital right now that is in 3 different languages is performing above industry standards. So have the benchmarks there so that you could see how much above industry standards we're performing. We have programmatic and paid social. So we're doing things like not just the social media platforms, but things that you see like pre-roll on websites and things like that. And again, this is just a quick snapshot on our digital and social work. But if you recall, we also have some PSAs that are running on air right now in English and Spanish. And then we have live reads going through ethnic media that are reaching 40 media outlets in 18 different languages. Our approach right now is to really be nimble and to be as quick as possible in reaching as many people as possible with those key messages that we've been talking about, that this group has raised in the past about ensuring that people know that have information on safety and effectiveness, about information being protected, and how they are free. And we're going to continue to build upon that messaging as we move forward. So next slide. And then just really quickly, we had mentioned before that we, part of our earned media efforts included not just, we're almost at a daily cadence right now in doing earned media appreciation to some of the folks, including our Surgeon General and Dr. Aragon, Dr. Pan, who have been with us in getting almost a daily cadence of rapid response out there to help share information in real time with ethnic media and general media. But on top of that, we also have ethnic media briefings that we've done with Ethnic Media Services and California Black Media in partnership with them. So we did 3 different media briefings over the last week or so that generated engagement with 79 different outlets and 90 pieces of coverage to date. And we hope that that will grow. And then we're going to continue to do them as we move forward, and both in February and March, bringing on a partner, Nuna, who's going to help us with our tribal communities. So just wanted to give you a snapshot that, how we did this in partnership with other folks, and trying to share information that's, is important to share, that can't be done in a 30-second PSA. That's where earned media really comes into play. And we want to make sure that we're reaching people with the information that they need. Next slide. And the next slide is just going to give you some samples of some of the stories that have come out of our earned media efforts. Next slide. And then wanted to note that we have some new graphics on our partner toolkit site. One is on My Turn that includes the call center number, because we know that folks sometimes want to, it's better for them to have in-person assistance or someone who can help them in person over the phone. So we do include the phone number there. So there is a connection between the call center and My Turn. Have these in English and Spanish now on our toolkit site. And then a web button so folks can continue to share the availability of the information that we have on our COVID website. So those are now on our toolkit website, and we're going to continue to create content, continue to translate, but just wanted to show you a sample of what we have so far since the last meeting. Next slide. And then one of the samples that I wanted to mention as we move in, as we're now in February and have Black History Month, we are going to be highlighting what we're calling COVID-19 heroes, folks that are on the ground, on the front lines, with supporting efforts to mitigate the spread, to get information out about vaccines and those key messages. So folks on the front lines, not just at a state level, but also folks on the ground. It's primarily a partnership with radio. We're going to have over 250 different radio spots, but it will also be amplified through print, social, and earned media efforts. And again, leveraging Black History Month to really reach our African-American Black community with key messages that we're continuing to learn and collect that need to be addressed with this particular population. So a really creative way of working with trusted messengers who are doing great work, at the same time addressing key messaging around vaccine. Next slide. And then I want to pass it over to Marcela, who will give you an update on our community engagement, and know that there is a lot more work now happening, that when we meet again, we'll be able to showcase, including potentially even a new PSA. There's a lot of work that's happening now. I'm excited to bring that back to the team to showcase and do a little bit more show and tell, but wanted to keep it short because we have a lot of really good content to discuss, both from Marcela and on our research. So Marcela, I'll go ahead and pass it on to you.
Thanks, Marisela. And I too will be quick so that other folks can present the really good content that we have on research. I wanted to provide everybody with an update on the community outreach campaign, and thank you again for inviting us into this space now for the second time. As we have talked about in the last couple of meetings, CDSS, the Department of Social Service, and the Labor Workforce Development Agency, we are jointly administering funding to support outreach to disproportionately impacted populations and people working in high-risk industries. And we will be contracting with about 150 organizations statewide to conduct that outreach. Next slide, please. What I would like to do today is to provide you an update on the timeline for the outreach project, and also to announce the second partner for the CDSS funding. As we have mentioned, LWDA and CDSS, we are both working through the Center at Sierra Health to administer the program. The center is administering the funding statewide on behalf of LWDA, and they are administering the funding in all counties except Ventura, Orange, and Los Angeles on behalf of CDSS. CDSS's partner for Ventura, Orange, and Los Angeles is the California Community Foundation. And like the Center at Sierra Health, CCF was a key partner for the state on census outreach and has critical partnerships and infrastructure to support outreach to disproportionately impacted populations. So we are thrilled to have them on board. What you are seeing is the timeline for what we are calling the 2 cohorts. The first one being the cohort with the Center at Sierra Health, and the second cohort being the California Community Foundation cohort. Cohort 1, we are very pleased to announce, goes live tomorrow, and the list of about 100 partners will be publicly announced then. They were informed on January 29th of the state's intended to fund them. We are working through some of the logistics to finalize the announcement, but as of tomorrow, that will be public. Over the next few weeks and starting tomorrow, we are going to be hosting a series of onboarding sessions while finalizing the contracting logistics for those partners who will begin their outreach on February 16th. Cohort 2, which is the CCF cohort, is currently in the selection process. CCF released their invitations on January 29th, and they are expecting to have partners selected by February 11th. And we are currently determining the dates for the onboarding, and we are anticipating that outreach will begin in March. Next slide, please. So we have presented some of the following information at a high level in the past, but wanted to just quickly circle back and spend some time walking through the approach, and especially spend a little bit of time talking more about the activities that we are going to be funding. As we have shared, this project is statewide, and we are focused on disproportionately impacted populations. Outreach priorities will be driven by data about COVID burden, or in other words, where we see the highest rates of COVID, and also by the Healthy Places Index and other equity indices that shows us the community is experiencing the worst health outcomes. The partners are going to have access to data, maps, and tools to help target their research. We are prioritizing high quality, or what we are calling interactive engagement, which includes training in person or online, phone banking, door-to-door activities, canvassing, and bidirectional text and emails. And I just wanted to explain that the reason for that is that the purpose of this funding is to ensure that populations that are experiencing the most burden and face access issues receive information that is relevant to them, their needs, and in their language, and that they are able to have their questions answered so that they can be directed to the appropriate resources. We will support one-way outreach, such as social media and traditional media, but that will not be the priority for this particular project. Ultimately, the goal is to direct people toward the vaccine, toward processes that are available to them to enforce their labor rights and other economic supports. We have received some feedback from CBO partners concerned that we may be imposing very strict activity requirements. And I just want to share with you that we certainly are structuring this to achieve outreach goals and want to evaluate the effectiveness of the outreach efforts. And so we are asking for plans and reporting, but we certainly understand that organizations may have to shift their strategies both to respond to conditions on the ground and to adapt to what we are jointly learning about effective strategies. So there will be room, it won't be a micromanagement of the activities, although we are absolutely going to be prioritizing those bidirectional engagements. Next slide, please. Finally, I just want to lift up again the populations and sectors that will be the focus of the outreach. The labor outreach will focus on the dissemination of information related to workers' rights, with a particular focus on industries in which workers may experience greater risk of contracting COVID. And you can see the list for yourself that includes agriculture. There's been a lot of conversation about farm workers. So farm workers are one of the populations that will be targeted through this outreach, along with workers in the other industries and sectors that are listed on the slide. The CBO partners will receive training and material to support the labor rights in the specific sector outreach. And finally, what I will lift up is another question or inquiry we've received from community-based organizations, and questions about the collateral and the outreach material that will be available for outreach. We are working with vendors and researchers to inform the content development. But we'll also want to emphasize that the experience and perspective of the CBO and philanthropic partners that we're working with is critical, and we'll absolutely want to collaborate with our CBO partners to develop assets and collateral as this project unfolds. Finally, I just want to thank those of you who have reached out directly, both to CDSS and LWDA. We have spoken and met with a number of you over the last couple of weeks, and really appreciate you sharing your concerns and your perspectives and your ideas. And we are always grateful for the feedback and happy to adapt the program where we can and how we can to more effectively partner and achieve our common goals of ensuring that disproportionately impacted populations are able to get to the vaccine, get to the resources they need, or enforce their labor rights. And so I will hand it over to Martha. Thank you.
Thank you, Marcela. I'm going to be talking through my phone, and hopefully you can hear me okay, Bobby. Sounds like you can.
Yes, we can hear you great. We can hear you great, Martha.
Thank you, Bobby. We can get to the next slide. Next slide, please. I think I spoke to you guys about 4 weeks ago when I joined back the California Department of Public Health team. We told you that we were working on onboarding a media agency. So I wanted to give you guys an update. We have found a multicultural integrated media agency that has a lot of specialized capacities and experience. They are Duncan and Shannon. They're bringing a slew of experts that will help us ensure that we have a multicultural campaign to reach all Californians. We're really excited about this team. They're very experienced, very creative. So we wanted to give you that update. Next slide. I also wanted to kind of share with you on their specific goals. They have a big task ahead of them. But they will be focusing on ensuring to have a strategic overarching approach for public health messaging. They will be also developing a statewide strategic media campaign that is cost efficient and maximized to reach communities disproportionately impacted by COVID-19, a lot of the communities that we've been hearing and talking about today, and also emphasizing the public health strategies and tactics to ensure users are reached. Their strategic approach will be sequential. They will be connecting, educating, normalizing, and activating Californians with very creative messaging and tactics. This is just an overview of their scope. As we progress, we will keep you informed of their efforts, but we're super excited to have Duncan and Shannon and the slew of experts that they bring on to this project. Next slide. We also, the last time I spoke to you, I talked about research. We have a very robust formative research that's really informing us to develop deeper understanding of the barriers, including the hesitancy factors, which is something that we're all very concerned and want to address. We also want to determine motivators for adoption, and also want to examine continuously the likelihood of Californians to get the vaccine. And overall, we want to make sure that we identify the best communication channels to deliver these messages. In order for us to do that, we have developed what we call 4 different stages within our research. We've done a comprehensive literature review. We've done some stakeholder interviews, which a lot of you participated. We're doing generational online infographic sessions, online qualitative and quantitative boards, and we have some data today to present. Next slide. One of the findings that we found from our qualitative online boards is essentially 4 specific barriers to vaccine hesitancy. Number 1 is lack of information and guidance from government agencies and health experts that has created a mistrust and fear that government is trying to control them. The second barrier is the anti-vaccine skepticism and the conspiracy theories that have led for misconception on how mRNA works and the DNA mutation and the potential of spreading the virus post-vaccine. The other barrier that has been examined is the historical incidence with vaccine. And we know that this has influenced the African American community and the Native American views on vaccination. And a lot of this is historical and cultural. Last but not least, the lack of efficacy and safety on data to spread, which the vaccine has developed and created questions of potential long term. These are the barriers that we have identified that we will be continuing to examine. Next slide. One of the things between our literature review, the stakeholder interviews, and even our online boards, the qualitative focus, we have seen a pattern. In order for us to empower communities to get vaccinated, we have to ensure that we have the right messengers. We need to ensure that we empower messages that are communicated to the community by trusted sources within each community that will resonate best for each segment. Someone that can be related to them or relatable to them and can speak some of the subtle nuances on how impacting it may be. The other sort of theme that we have seen is the dissemination of information in language and in culture. This is going to be really critical, and we are already doing the work, and you've been seeing that with the current communication efforts, that messages communicated by trusted sources in language and culture will be super, super important. The other theme that we've been seeing is humanizing lived experiences. Testimonials of real people in various population segments who can share their experience with COVID-19 and the vaccine, like why they got it, the importance, how it will impact them, their families. This is something that also communities want to hear from their peers, from their family, from their friends, from their neighbors. They want to learn how people are experiencing as they're going through the pandemic. The other thing really important for us is really using channels to reach audiences where they're at. We will be meeting people where we're at from our air game and also through the resources that we'll have through this campaign. We have to share messages where people are consuming information beyond traditional channels and based on population segment tapping into localized CBOs, which Marcela talked about that, local news media, which Marisela also touched upon, and especially with the ethnic media outlets. That will be a really critical tactic that we will be leveraging on. Next slide. I wanted to share stakeholder interview key findings. A lot of you guys helped us in really identifying, and we want to thank you for your participation. The key messaging that you had suggested is highlighting the safety and the benefits of the vaccine, to integrate the concept that everyone is working together, and also to focus on how the vaccine helps family and community, and to address the side effects. And something that it's not new to all of us is that we know that there's a distrust in government. Some of the recommendations that you gave us in terms of trusted sources or messengers or influencers are doctors, medical professionals, religious leaders, promotoras, health navigators, and trusted community members, along with community health workers and cultural centers, family members and caregivers, along with legal, health, and social community activists. These are community influencers that could deliver the message per your suggestion. Next slide. Some additional barriers that you also shared with us in terms of vaccine acceptance is, there's a fear of deportation, especially with our immigrant community. There's a lot of myths about the vaccine. There's fear of being used as a guinea pig. There's also perception that the herd immunity is better than the vaccine, or that the number of dosages and gap time between the dosages, and also just concerns about the effects of the vaccine on pregnancy. There's a lot of concerns that you have identified for us that we will be taking into consideration to ensure that we can provide credible and reliable education and information. Next slide. We also had consumer findings with dyads and triads, which is parents and their children, and sometimes it was just a parent and a child. We did these across California, and one of the things that they told us that the COVID vaccine was has tremendous emotion, and this is something that we're seeing as a common theme. There's a lot of anxiety, fear, frustration, and anger surrounding this topic, which causes a lot of the cognitive distancing. There's layers of confusion that feeds into that hesitancy. There's decision-making that is happening moment by moment, and this is something that we also saw in the literature. There's fear and confusion of vaccine availability and eligibility. There's concerns that even taking the vaccine, one can still spread the virus, further influencing hesitancy. These are the top themes and topics that rose up when we talked to parents and their children, which was really also correlating to the findings that we had with the stakeholders and the literature. Next slide. This slide, we wanted to really put the information in a way that allows us to really understand that the barriers go beyond just vaccine specific, there's a systematic social, cultural, economic influence, there's an emotional influence, there's a behavior cognitive repercussion, and then there's also the vaccine specific into the gaps. This really speaks to what Dr. Nadine Burke-Harris talked about, the institutionalized racism, the social determinant of health. All these things are really influencing how people are understanding, receiving, or even making decisions. For example, on the systematic social cultural, we're learning that the discrimination and equities within healthcare and insurance systems is being magnified. The not having healthcare or proper housing or access to food, the food desert, that's all magnifying the discrepancies, and it's influencing these barriers. The emotional influence, COVID-19 has become very emotional for a lot of us for various reasons. And there's also just the mechanics of fearing of the DNA alteration. These are real concerns that people have, or just the cognitive repercussions of misunderstanding of herd immunity and its imperatives, or just the efficacy of the length of the protection or the rollout or the distribution and schedule of the vaccine. These are real gaps that really are leading to the hesitancy that we will work on and ensuring that the education and information meets the people's needs to make the most informed decision. Next slide. To continue our formative research, as we mentioned, we'll continue to monitor the community. So we will continue to have monthly online boards and panels that start next week. We're also going to continue doing some focus groups on attitudes and beliefs. Recruitment and scheduling is happening now. We're also going to continue to test creative testing. We will also be doing and ensuring an advertisement tracking study to ensure that the recall of our efforts is very quantifiable to our communities, and ensuring that we're meeting and reaching the people that we intended to reach. Next slide. I think I will pass it now to Dr. Arlene Brown. Thank you.
Thank you so much. And I want to thank you for inviting me to present here today. I've been sitting in on a lot of the sessions, and I've been so impressed by the thoughtful questions and conversations, including the amazing recommendations in the chats. So I'm going to present very briefly work we're doing around Stop COVID, called Stop COVID-19 CA, and it's Shared Trust Organized Partner, the COVID-19 California Alliance. Next slide, please. So this was funded by the NIH. It's a project that was funded last summer to really focus on urgently needed community engaged research and outreach around COVID-19 awareness and education. And it's the NIH, so they were very interested in figuring out ways to make sure that there was a diverse cohort of patients included in the COVID trials. That wasn't why we got involved, but we were one of 11 states funded. Our California Alliance, next slide, please. includes 11 different academic health centers and about 70 community partners. And our goals were multifold. One thing we wanted to do was really try to understand barriers and facilitators to understanding COVID-19, risk testing and prevention, the feasibility and acceptability of a potential of participating in the vaccine trial, and what were going to be the challenges to uptake of approved vaccines across high-risk communities in California. We also wanted to work collaboratively and really think about culturally and linguistically tailored strategies for reducing these barriers, and then identify best practices for working between academic institutions and community partners. Next slide, please. So we have 11 sites across the state. They're listed here. And then we have about 70 to 75 community partners now. Next slide, please. The community partners, you don't need to read all of them, but I just wanted to highlight that they're a really diverse group. And they're often partners who have worked with these institutions for a very long time. Next slide. So our projects, the idea behind the projects was not to try to do one thing across the state, because we felt that that would make no sense, particularly because many of these community partners had longstanding relationships with the academic health centers they were working with. So what we tried to do was really think about having each site work collaboratively on specific projects that made sense in their community. And I list here some of the things that we've been working on. So we've talked about, and many of these things are things that you as a group have discussed and that the prior presenters have described. So trusted education and outreach from community health workers, community organizations who are well-known, local media, their health fairs that actually have restarted despite the pandemic in certain parts of the state, and then using the visual arts as well. There's also qualitative research, and I'll describe some of what we found here. And we've done focus groups in multi-ethnic communities, as well as something called deliberative community engagement, where you do a very focused group of discussions around a topic. We've also tried to work on capacity building, training, both of the community health workers and of the media, but also it's bi-directional training. We're learning a lot from the community health workers. And then we've done some surveys and needs assessments, and then engagement in the trials. The populations we've worked with are listed here. So Latinx, including monolingual Spanish, African-American, Pacific Islander, American Indian, Asian, Filipino, Chinese, and South Asian in particular, essential workers, immigrant populations, including refugee populations, the LGBTQ population, and many low-income groups across different communities. Next slide, please. So just to give you a sense of some of the work that we're doing statewide, we've actually collaborated with the California Health Interview Survey to create a dashboard of COVID questionnaires that they've developed and used, and they've also partnered with others to deploy. So these are questions that they used between March and September of 2020. And then moving forward, we're going to be asking more detailed questions, including questions about vaccine uptake across the state. As many of you know, CHIS is fielded in English, Spanish, Cantonese, Mandarin, Korean, Tagalog, and Vietnamese. We're also working, they're also going to be asking some questions about discrimination related to COVID. There's ethnic media outreach, as I mentioned before, and then community academic co-development of training protocols. Next slide. So I'm going to describe a few of the things that we've worked on. We've really tried to take locally informed approaches, leveraging existing networks. And we've worked with people who have been considered in the past trusted leaders. So to date, we've had about 120 COVID-related webinars, town halls, and community meetings. We've reached about 10,000 people on the first wave. Many of these are posted, they're on YouTube, and they're accessible for future viewing. In LA in particular, we've actually worked very collaboratively with the clinical trials, because one of the concerns that we heard time and again is that people in the trials don't look like us. And we've worked both with the vaccine trials, but also the monoclonal antibody trials. And at least for the vaccine trials, our minority participation rate is 70 to 75% which is far higher than the national average. And then we tried to disseminate real-time results about some of the work we're doing. Many of you know, as academics, we are really slow. And we tend to we're very sort of pokey with the work that we do. And what we've tried to do is, as we've learned things, we've tried to push them out. Next slide. So these are examples of some of the things that we've done in the LA, both LA and up at Stanford. So we've done articles for a local African-American paper, the Sentinel. There's a Black Health Trust, which is a national entity, but it's based in LA. And we've presented on their national forums, which happen every week or every other week. And then at Stanford, they've done community town halls where they do outreach in English and Spanish. They have a clinical expert, they have a public health expert, and they have a community expert at the table. And the questions are fielded by providers who type responses in the chat in English and Spanish. Next slide, please. And then these are some examples of what has been labeled community-friendly materials, and things like this picture of the scales, where just getting the point across about the importance of vaccination, for example. Giving people too many statistics are sometimes not useful, but this has really resonated with many of our audiences. Weighing the risks of infection versus vaccination. So for every million cases of COVID infection, there are about 15,000 deaths and 70,000 hospitalizations. And for every million COVID-19 vaccinations, there are 2 to 3 serious reactions, 1 to 2 hospitalizations, and 1 to 2 deaths. The other things that we've heard time and again are this is happening too quickly. So our team in San Diego created this timeline of mRNA technology and talked about the fact that this was developed way back in the 1990s. So it's not an untested, unknown technology. And they point to the diverse people who've been involved in the vaccine development, but also they point to people, local investigators and local team members who have participated in work that contributed to vaccine development. Then finally, the lower left-hand side shows, describes who was in the trials, but also takes a different spin on it. It talks about the effectiveness overall of the clinical trials. So for example, in Moderna, it's 94% effective overall, but it was almost 98% effective in people of color. For Pfizer, it was 95% effective overall, but 100% effective in Black individuals and 94% effective in Latinx individuals. So giving people a sense that yes, we participated in this and we benefited from it just as much as those who traditionally participate in clinical trials. Next slide, please. And I'm not going to go into a huge amount of detail, but these are some of the preliminary themes sort of were in these buckets. A lot of questions, need for information and concerns. And many of the concerns were pointed to earlier. It was fetal tissue used in the development of the vaccine. Did the people who participated in the trial look like me? But a lot of issues around social determinants and accessibility and affordability. Things like transportation. How am I going to get to the Dodger Stadium? Because it takes me 3 buses to get there from South LA. What am I going to do about childcare and elder care? And we encountered this both when we were talking to people about participating in the trials and in getting the vaccine. And we actually, as part of the clinical trial, what we ended up doing is providing transportation for people to get to the clinical trial site if it wasn't in their community. And I think we as a society have to think differently about how we're going to provide access. So either providing a vaccine at the work site or getting people to the vaccine sites if they want to do it. There were some population-specific concerns, some concerns about residents' legal status, and not just your own legal status, but the legal status of others in your family or others in the community. And were you putting them at risk by having people come to you, contact tracers come to the home, for example? And I think there was also a lot of positivity diffusely among the different groups. There was a ton of altruism. Doing this for your family, for your community, for the society as a whole was really important. And so, despite the fact that there was a lot of hesitancy, the other thing that we heard time and again is if someone would sit down and talk to me about this a little bit and answer my questions, there's a much higher chance that I'm going to participate in this. And so I think we felt very strongly that this was a message that came through time and again, and we'd love to make sure that people hear that. In the clinical setting, when I'm seeing patients or if I'm seeing patients with the residents, I always say, make sure that you ask people, if they say, I don't want the vaccine, ask them why. It's not going to be an intense or a long discussion necessarily, but it may raise issues that you haven't thought about. And they may be issues that are potentially addressable. And if they still don't want to do it that day, you can talk to them about it the next time you see them. Next slide, please. And then finally, this is just, we've actually consolidated some of the frequently asked questions into a couple of fact sheets. This is the English version, there's a Spanish version. The idea is this doesn't necessarily go to individuals in the community. Instead, it may go to the community health workers who are doing the outreach. And we're trying to do this electronically so that as they often say, I don't have the answers to some of the questions that are coming up, but providing them with this sheet, giving them the information that they may need. And then I think the other thing that has come up time and again in our larger working group is that there is a real need to make sure that the people who are on the front lines providing this information get their questions answered and their concerns heard and raised and addressed. Because I think that we have found working with several community health worker groups that there's reluctance to talk openly about their concerns about the vaccine at times. And so I feel sometimes there has to be a clearing of the air, making sure that issues around that distrust of the medical enterprise and the research enterprise and their own barriers to maybe getting the vaccine themselves are addressed open and explicitly. So I think that is the last slide. I'm going to stop here and thank you again for giving me this opportunity.
Thank you so much, Dr. Brown. And at this point, I want to recognize that we are significantly behind time on the schedule. I think we wanted to provide responses to your many, many questions, but we might have overdone it a little bit in terms of our amount of content in this meeting. So we'll go ahead and take 5 minutes of questions. Anything that we can't take in that time, please go ahead and put in the chat, and then we will move to wrapping up.
Great, so let's start with Denny Chan and Dr. Tan, and we'll just hear from the two of you. And Diana, please put your comment in the chat. I'm sorry, we won't have time.
Hi, everyone. Thanks, Bobby. Denny Chan from Justice and Aging. I feel like the last 2 meetings I've gone at the very end, so I'll try to be super succinct in my comments. This is more of a comment than a question, really, and what I'm hoping, what I can encourage the state and all of us to do is really think about equity. We've talked a lot about the different strategies moving forward, whether it's contractually, what equity looks like in terms of messaging. And I kind of want to bring it back to 1B Tier 1, the 65 and older individuals who are trying to get the vaccine now. Because it's great to have these strategies moving forward and have them inform our strategies moving forward. But what we know on the ground, we're seeing tons of disparities. We're seeing, in the news, lots of disparities. People who are 65 and up who are getting the shot are predominantly white. And that, is building upon train tracks that have long time fueled disparities to begin with. So what I fear that what we've created as we're transitioning to the third-party administrator system is a kind of open system where you can go and get it if you can get it, that really rewards privilege and access and capacity, and that puts people who are 65 and up and particularly harmed by COVID-19, older adults of color, in the back seat. So I know that we're under tremendous pressure, and I know the state's under tremendous pressure. They're doing the best they can, but I do want to lift that up because, equity will mean that older adults of color, people who are homebound, people who live in rural communities, they need to have access just like everyone else. And what I fear that we aren't spending enough time on is drilling down on strategies to actually reach these people, the 65 and up, who are right now getting vaccinated. And to give you just one concrete example, if you don't speak English or Spanish, and you are living in the county of Los Angeles and you're trying to schedule a vaccination appointment, good luck, because the web page, all it has, other than haga una cita en español, is a globe in the top left-hand corner that embeds Google Translate. So I think it's great that we're talking about equity in the third-party administrator system, moving forward, what that looks like, but we have people who we've already prioritized in 1B, tier 1, who need to get the vaccine now. And you can do whatever messaging you want, but they need to actually be able to sign up for a vaccine and have it reach them. Thanks so much.
Thanks, Denny. Dr. Todd?
Yeah, part of my comments really echo what Denny said. But first of all, I just want to say, oh my gosh, the incredible work that the outreach and engagement team has done is just really amazing. And I want to just, first say such kudos, evidence-based, really useful information. I think that to speak a little bit more to what Denny was saying, I think a lot of what we're talking about in terms of outreach is really about how to activate people. But there's that second part that is so important, which is the navigation part. If we activate people only to have barriers like the website, as Denny mentioned, what happens is we end up demoralizing people and confirming that the system is made for a certain kind of person. And so that is my big concern, that when we are doing all this like wonderful outreach work and say, yes, do have the vaccine, it's essential for your family. And then when people are activated, they're unable to make it. And then they feel internalized guilt, their family members feel guilty, and there's a sense of demoralization, again, from the system. And so I think that I really want to highlight several things that was said that I feel are important solutions to build upon. One is, promotores and other health navigators. I think that this is really essential. It takes such a high level of literacy to try to navigate through the current system to get to a vaccine, not to mention the other social determinants such as transportation. The other thing I'll say is that there's a real opportunity here using a place-based approach, because when we use a place-based approach, we have the opportunity to really coordinate the activation with the navigation, with the access to the clinics, because we're doing it in a local setting. So I really want to emphasize that we have to consider messaging and outreach with navigation, with access. And then the final thing I'll just say is that there's a real opportunity when we have a place-based approach to really build upon community partnerships that exist. And I'd like to really encourage us to think about what are the ways to incentivize the kinds of partnerships that exist across different CBOs, across CBOs and academic health centers and health systems. We really want to leverage that. And the best way to do that is using a place-based approach.
Well, I want to thank everyone for another really robust discussion and for all of your wonderful participation. This is what makes this process better, and we're very grateful for the engagement of all of the members of this committee. There was so much that was said in this meeting, and I like to summarize and reflect on what I've heard, but I recognize that we are coming to the end of our time. But I want to highlight that we're going to again, engage in a process. All of the questions that weren't able to be answered that were put in the chat today, we'll take it back to our teams, do our best to come back with solutions and answers and responses. And the thing that I really just want to close by saying is that your engagement, and that is the engagement of the public through public comment and the engagement of every single member of this committee, is making the process better. And what I hope that you can see throughout these meetings has been our incredible effort to incorporate as much as we can of the excellent recommendations and suggestions that you all are sharing, so that we can have a process in California that's based on our core principles of safety, equity, and transparency. So with that, thank you so much. Our next meeting is
February 17th.
Thank you.
2 weeks.
Thank you. It's in 2 weeks, February 17th from 3 to 6 p.m. Thank you all again, and we look forward to seeing you at the next meeting.
Thank you very much, everyone. Have a good evening. Thank you.
Thank you.
Thanks, everyone.
Bye-bye.